We are live now, Doctor.
A very warm afternoon and welcome to one and all gathered here. We from Team Young Ophthalmologist Society of India welcome you all for YOSI iROCK International Season 2, a concept conceived by Dr. Nupur ma'am and team. Residence Ophthalmic Compact of Knowledge is the tagline for this event, where we have 5 sessions from iLeague, Pupils Got Talent, Knowledge Nexus, Wordsmith War, and Audience Prizes. So this is an event which was again we welcome Nupur ma'am once again, who was one of the brains behind it along with Dr. Divakant, where we had this prelims last year followed by a finale at YOSICon. Similarly, this year also we are having a similar pattern where we are having 4 preliminary sessions, but this year we are going international with it. And I also warmly welcome all the 4 judges, Dr. Parul ma'am, Dr. Sati Devi ma'am, and Dr. Manish sir, whom personally I've learned a lot in glaucoma, and along with them a dynamic colleague from Indonesia, Dr. Vidya Anandita. And myself, along with Arshi and Harshal, will be the 3 moderators. And this is an event where teams will be going against each other. And we have 6 teams today. One of the teams, unfortunately, had to drop out. We have Team Visionaries, Team Vision Makers, Ora Sereta, Team Igotis, Team The Prisms, and the KY Jellies from Malaysia, joining us today along with Team Eagle. Next slide, Harshal. So yeah, these are the participants. We have a short video for it. Arshal, please play the video. Thank you, Arshal. As you saw there, the video was quite self-explanatory. Our team, led by Dr. Divakant Mishra, our dynamic president for this tenure 2024 to 2026, followed by the governing council members. Arshal, next slide. And we have around 20 dynamic executive members to help us. Dr. Arshi is one of them, who's also a co-moderator for today. Yes, next slide, Arshal. And we also have in YOSI multiple dynamic arms. So for all the attendees in YouTube and our global audiences, you can see Team YOSI, we have multiple arms and we cover a 360-degree coverage of fellowship help desk, medical legal, job portal, ocular emergency, Times, magazine, and residence network. And this iROCK International is one of the arms that has recently popped out for the last 2 years. Next slide, Arshal. And we have 34 residents, a team pan-Indian representative. Even today, if you see, we have a complete 360-degree coverage of pan-Indian representation along with a team from Malaysia as well. 8 online prelim sessions happened. This was all last year. 3 semi-finals, 1 physical final, and 1 grand finale at the 2nd annual YOSICon, where 7 YOSI iROCK superstars were crowned and 3 YOSI iROCK superstars, 7 teams, and finally 3 member team won the superstar award. Next slide, Arshal. And these are all the previous year events that we did. YOSI iROCK, which, next slide, Arshal. Yeah. Next slide. So these are all the previous events where you can see that it culminated at New Delhi last year, September 5, 6, 7. and it culminated at YOSICon, where Team Macular Goals won the first prize to be crowned as the superstars, along with Multifocal Warriors and Arts Triangle. Next slide, Arshil. So this is the video of the same. The whole idea of this event is to mix camaraderie along with science, and then get into something very, very innovative for our residents. And this year, YOSI iROCK has gone international, where best residents across the globe are participating in it. And we have a tremendous response from all around the globe for this event. Next slide, Arshil. And this is the YOSI iROCK team, as I told, led by our dynamic Dr. Nupur Goyal madam. And many people behind the scenes have worked extensively hard. Dr. Priya, Dr. Harshil, Dr. Ritu, Dr. Mausmi, Dr. Ritika, Dr. Pranesh, Dr. Samir, Arshi, Dr. Lippi, Roma, Sahil, Dr. Samita, and myself. These are the team who have really done the background work, along with Dr. Nupur ma'am, who has been at the helm. Next slide, Arshil. And these are some of the guidelines, where each team will have 3 members. Only JRs are allowed to participate. The finale is the top 2 teams in each prelims will go to the grand finale at the 3rd annual conference this year, July 10, 11, and 12. And the results will be announced the same evening after the marks are compiled and validated. And e-certificates to all the participants. And we will take 8 finalists this year for the YOSICon event, which is going to happen physically, who will also be given travel grants for the event. Details will be shared soon by our office bearers. Finalist team, all members need to be physical, and 3 people will be, 3 teams will be in the grand finale, and 1 will be titled the iROCK Superstars YOSI International. Yeah. Next one, Arshil. Yeah, these are the flyers for the previous 3 events that we had. We had a subspecialty retina, cataract, and oculoplasty. And these are the 3 winners of the 3 prelims who will be going to the finale. Next one, Arshil. Yeah, the rounds comprise of the 4 modules which we just discussed. Is it a video, Arshil?
No.
Yeah, these are the 4 which Dr. Arshi will be sharing in detail, along with Dr. Arshil. Next, move to the next one now. And the audience prizes are also there to be won. So please stay tuned, dear audiences, where you have multiple prizes to be won. Yeah. So with that, I hand it over to Dr. Arshi, my co-moderator, to start the proceedings and take it forward. Over to you, Dr. Arshi.
Thank you, Dr. Prasanna. So it is my proud privilege to introduce the judges for today's sessions. So today we have joining us Dr. Vidya Anandita from Indonesia. Madam is working as Mayapara Eye Center in Indonesia. Thank you for being with us today. We also have with us Dr. Manish Singh. Sir is a senior consultant at Netralyam, the super specialty eye care center in Kolkata, and a dynamic member of the GSI Society. Thank you, sir. Next, we have with us Dr. Parul Pujani. Madam is a professor of glaucoma and neuro-ophthalmology services at the Department of Ophthalmology at Government Medical College and Hospital, Chandigarh. Thank you, ma'am, for being with us. And last but not the least, we have Sati Devi, ma'am. Ma'am is working as a consultant at Narayan Netralaya in Bangalore and is heading the glaucoma services there. Thank you so much, ma'am, for sparing your time. And I'm sure that the participants today will learn a lot from all of you. Moving ahead, the moderators for the session today are, we have with us Dr. Prasanna. Can I have the next slide, please? Dr. Prasanna Venkatesh Ramesh, sir, is the Research Director and Head of Glaucoma at Mahatma Eye Hospital in Trichy, India, and also part of the Governing Council of the Young Ophthalmologist Society of India. I am an assistant professor of glaucoma services at Guru Nanak Eye Center, and we have with us Dr. Harshal Sahare. Dr. Harshal Sahare is working as a vitreoretina consultant in Tirunelveli. Nice to have all of you over here today. And moving on to the participants, we've already had a beautiful video introducing all of you, but I'm just still going to go ahead and give your names to the judges. So the first team is very interestingly named the Prisms, Precious, and the Periphery Squad from Guru Nanak Eye Center, Maulana Azad Medical College, led by the team captain, Dr. Shaumya Kashyap, and Dr. Nehal Bhandari and Dr. Jyoti Garg will be part of the team. The second team for today is the KY Jellies, and they are from Hospital Selayang in Malaysia. And we have Dr. Chan Chin Ying, we have Dr. Maggie Boon Yi, and Dr. Chong Karyong. Nice to have all three of you. Then we have teams Aura Siriata. This is team 3, led by Captain Dr. Sanskriti Pandey. They are from Eye Care Eye Hospital and Postgraduate Institute, Noida. And other members are Dr. Pranjal Atolia and Dr. Shefali Patel. Nice to have three of you. We have team Visionaries, led by their team captain, Dr. Surbhi Bharadwaj, and their team members, Dr. Nitin Gaba and Dr. Rekha Bharadwaj, again from Guru Nanak Eye Center, Maulana Azad Medical College. We have team Vision Makers, led by their team captain, Mohammad Afzal, who is a resident at Army Hospital and Research Center, New Delhi, and the team members, Dr. Abhishek Singla and Dr. Sahil Kumar. The next team is team I Got This, again, a very interesting name, led by their captain, Dr. Akansha Das, a final year resident, and the team members, Dr. Mukul Gupta and then Dr. Disha Shri. We have these 6 teams participating today, and thank you so much. Moving on to Dr. Harshal, please introduce the Governing Council.
Thank you, Dr. Arshi. I just like to introduce Dr. Divyakant Mishra, sir, the president of GC, and I just want him to address some few words, inspiring words for our participants. Over to you, Dr. Divyakant Mishra, sir.
Dr. Harshal, sir is unable to join right now. He will be joining, I think, in some time. When he comes,
Sir,
we can take him.
Yeah, I'd like to introduce Dr. Nilesh Kumar, sir, that is General Secretary. I'd like to address our participants with some inspiring words and about the GC Scouts. Over to you, sir.
Thank you, Dr. Harshal. And on behalf of Governing Council, like in each of the webinar and all the platforms, I say it openly that this team and this series has been the most consistent one throughout any initiative that YOSI had taken in last 2 years. And that is all thanks to Nupur ma'am, her guidance, and then the team that is supporting her in the cause. Really great work, and we are very happy to see that this preliminary round is now today getting over, and we are going to get the finalists to come to YOSICon. And I would like to request all those who are not able to make it as a finalist, please still consider to come to YOSICon and join us at from 10 to 12 July at Hotel Pullman AeroCity, New Delhi. This is going to be worthwhile because the conference is curated for young ophthalmologists, specifically keeping in mind the residents and
we just lost you, Nilesh. Are you audible? Harshal, can you hear him?
Yeah, I can hear you, sir, but not him.
Okay, Harshal, can you stop sharing your screen for a moment?
Yeah.
Nilesh,
Now I would like to invite Dr. Prasanna, sir, our Joint Secretary, to introduce update about international delegate. Over to you, sir.
Yeah, Harshal, can you just stop your screen for a minute?
Yeah.
Okay, thank you, Harshal. Sorry for the technical glitch on behalf of Dr. Nilesh. So we wanted to invite you all for YOSICon, and this is an update from YOSICon team as well as the whole GC. Is this YOSICon, we are moving global, as one of the visions of our president is to move towards global ties with all young ophthalmologists. And as you can see here, as of now, we have 38 countries on board, starting from Nepal, Bhutan, Myanmar, Taiwan, Egypt, to name a few, along with all the Asia Pacific countries, the Middle East, like Libya, Tunisia, the South Africans, Maldives. We also have the Europeans on board, Switzerland, Germany, Russia. So YOSI has left no stone unturned to make sure that we take the global YO League forward with the initiatives such as the global YO ties that we are strengthening. And 38 YO ophthalmological leaders, along with 225 registrations and 2,000 plus national registrations, are expected at YOSICON. July 10, 11, 12, as our Secretary Dr. Nilesh was telling. We would like you all to be there, irrespective of whatever the results are, and we would like you to enjoy the conference and the camaraderie. Thank you, Dr. Arshal. Yeah, we can move forward.
Now I would like to introduce our Vice President, Dr. Karan Bhatia, sir, to address few inspiring words for our participants. Over to you, sir.
I think Karan is, yeah, he's
He's
here.
here. Karan is here.
Yes. Just on
So,
time.
congratulations to the team for a wonderful, event, and to the mentors as well, and to the participants. You guys are doing a fantastic job. I'll cut it short and say all the best, and looking forward to see you all at the third YOSICON 2026 from 10 to 12 July at Hotel Pullman, Aerocity, Delhi. It's going to be a big blast. It's going to be a party like no other with an academic extravaganza. So thank you.
Thank you, sir. Now I would like to introduce our team mentor, Dr. She doesn't need any introduction. Dr. Nupur ma'am, over to you.
Thank you, Harshal. Thank you, Prasanna. Thank you, Dr. Arshi. And thank you, Dr. Karan, Dr. Nilesh, for those inspiring words. So I think this session is especially very, special, because I would just like to address that this is probably the last online session of the team iROCK 2024 to 2026, and the last of this term of this, entire YOSI team. So after this, the new team will be taking over. Dr. Karan will be taking over as a president, and I think it's been a wonderful journey, right from session one, where we had absolutely no clue how to go about, and the success of around 11 online prelim sessions and semi-finals led to the idea of going it global. And we've received such a wonderful response, and I think a huge shout out to the entire team iROCK, Harshal, Arshi, Prasanna, Priya, Sameer, Lippy, Roma, Sahil, Ritu, or any names that I may be missing out. This is probably the best team that I have worked with. What you're seeing online today may look very simple. It's just a webinar, but many of you don't. It's a for one session of iROCK prelim session online, the team starts working 3 weeks in advance with constant trial runs and coordination. So I think a huge hats off to the entire team for pulling this off so brilliantly. Again, for this season, we've had a marathon of 1 month of Sundays 2 to 4 p.m. of 4 different specialties, and it's so wonderful. And again, a huge shout out to all the residence teams. I think it's just about coming forward and participating. That itself takes a lot of courage, to give seminar presentations, to make creative videos, and doing it with so much confidence. And I'm sure it's a good learning process for you, but with you guys we also get to learn so much. And welcome to all the judges for taking out their time on a Sunday afternoon, and wishing all the best to everybody. And I think I'll not waste much time, and we can just proceed with the the session. So wishing all the best to everyone, and we look forward to seeing all of you at YOSICON 2026. Back to you, Dr. Harshal.
Thank you, Nupur ma'am. Now I would like to hand over this session to Dr. Arshi ma'am.
All right. So
to
the
start our
outline
session.
of Thank you so much, Harshal. Outline of the session today is, as we just discussed, we're going to have 4 rounds. The first round is iLeague, the seminar presentation, followed by the second round, which is to be judged by our judges, which is Pupil Got Talent, which is actually a creativity contest in which they collaborate and they can create a awareness reel or an art form, which you have to judge. So, and then we'll have the quiz and the wordsmith war. So now we'll move on to the first round, which is the seminar presentation. And I like to invite our very first team, the PPP squad. The rules for the round 1 are, again, you've been given a pre-decided topic around 2 weeks back, and now you have to present on this in 5 minutes. If you exceed time, you will have negative scoring for that. This will be followed by question and answers. Also, judges to note that the mentors for the teams will be joining us for this round, and we'll be inviting comments from them after the presentations by the teams. And this round consists of 20 marks, and today's topic is glaucoma. So, first team, PPP, the topic is uveitic glaucoma. You can start screen sharing now. Dr. Harshal, if you could stop your screen share. KY Jellies, be prepared, you'll be the second.
Team 1,
Archie, you can keep a timer also once they start presenting and once they are ready, so that the timer is visible on the screen.
team
Yes,
1.
ma'am. Dr. Prasanna, could you please take care of the timer?
Yes, Harshi.
Thank you, sir.
All team, please note it is 5 minutes only, not 5 minutes, 15 seconds.
But we'll give them a leeway of 15 seconds. Yes.
All right. Timer on, please, Dr. Prasanna.
Yeah. Manjula ma'am, can you share the timer once again, ma'am, with me?
I think we can go ahead. I'm keeping time right now.
Yeah, I'll also keep
Good
Manjula
afternoon.
ma'am, can
I will
you
be presenting.
one
Should
second,
I start, ma'am?
1 second, doctor. Numerotic team,
Yes, doctor.
can you share the timer once again, ma'am? Not able to gain access to it.
Yes, doctor.
If you can share the timer once again. Yes.
Sure,
Open.
doctor.
Ma'am, we cannot see the timer.
1 second. We are just.
Yeah.
Now can you see it?
You can see the
yes, yes.
timer.
Can you see
Good
it?
afternoon. We will be presenting on uveitic glaucoma. So, a 32-year-old female presented with chief complaints of repeated episodes of redness and diminution of vision in the left eye with headache, on treatment with steroid eye drops and hometropine and tablet acifir for the past year on and off. Now with an IOP of 40. We can see she presented with circumciliary congestion, keratic precipitates, AC reaction, and posterior synecdoche. Now, how did this patient of uveitis develop an elevated IOP? Well, there are many mechanisms that can contribute to it. In inflammatory hypertension syndrome, IOP rise coincides with inflammation. Seen in viral etiologies, the cause usually is trabeculitis. If IOP elevation persists for days after inflammation, it could be due to angle closure by pupillary membrane or uveal effusion. Persistence of elevated IOP weeks after inflammation can be chalked up to steroid-induced glaucoma. And with waxing and waning pattern of inflammation, if IOP persists for months, it can be due to a mixed mechanism of angle closure by pulling by peripheral anterior synecdoche or by open angle trabecular damage. Now, our clinical approach should include an extensive history with prior uveitic episodes, medications, systemic symptoms to narrow down the cause, thorough examination with proper documentation, and targeted labs and imaging should be based on clinical suspicion, as the cause of most of these is idiopathic. Some common clinical associations are glaucomatocyclitic crisis, which presents as acute unilateral recurrent episodes in 20 to 50 years age of patients with elevated IOP, corneal edema, non-pigmented KPs as can be seen in the image, mild interior inflammation with characteristically no pass, and minimal findings in between attacks. Optic neuropathy is seen in a quarter of these patients. Management includes anti-glaucoma medications, topical steroids, oral NSAIDs, but these do not work prophylactically. If prolonged course is seen, then aqueous humor PCR should be ordered for CMV DNA and if positive, topical or oral ganciclovir should be started. Fuchs uveitis syndrome or Fuchs heterochromic iridocyclitis presents as chronic non-granulomatous unilateral low-grade uveitis, equally in males and females of 20 to 45 years. Clinically, iris nodules, either keepy or diffuse, are seen with heterochromia, posterior subcapsular cataract, and diffuse stellate-shaped KPs present on the endothelium. IOP elevation is seen in 13 to 59% of patients with fine angle neovascularization and rare synechiae. Now, these fine angle vessels can present with ampsilovery sign, which is either spontaneous or iatrogenic hyphema. Juvenile idiopathic arthritis presents as bilateral non-granulomatous asymptomatic uveitis, mostly in pauciarticular, that is JIA involving less than 4 joints with ANA positivity. IOP elevation here is majorly due to pupillary block glaucoma. It is important to have a high clinical suspicion in these patients and perform regular screening for uveitis. Other than the usual therapy, immunosuppressants and goniotomy have a role. Viral uveitis, herpes simplex and varicella zoster have an acute and recurrent course with small KPs and segmental transillumination defects, whereas CMV may present with a chronic course and coin-shaped large KPs and iris atrophy is diffuse. When a viral etiology is established, it is important to treat the infection with antivirals along with agents to lower IOP. Now, our management should first include baseline documentation of the disc and visual fields, among others, and initial treatment should be focused on targeting the cause of uveitis. If gonioscopy reveals angle closure, laser PI should be done for the same, followed by medical management of raised IOP and surgical if indicated. Medical management includes first-line therapy by beta blockers, carbonic anhydrase, and other aqueous suppressants. IV mannitol and oral acetazolamide have a role in acutely elevated IOP. PG analogs due to macular edema and increased inflammation, and cholinergic agents such as pilocarpine due to synechiae and blood aqueous barrier breakdown are avoided. Ripasudil, a Rho kinase inhibitor, has proven to have a role by decreasing inflammation and IOP. Laser procedures such as laser peripheral iridotomy have a role in angle closure and iris bombay formation, where we focus on the most convex part of the iris bombay and use a low energy. Cyclophotocoagulation has a limited role in a quiet eye with steroid-induced glaucoma. Now, once we have established that medical management is inadequate, and ideally we have a quiet eye for 3 months, surgical options can be considered. Trabeculectomy with antimetabolites and glaucoma drainage devices both have chances of failure, but glaucoma drainage devices such as Ahmed glaucoma valve have a clear-cut indication when the patient is young, pseudophakic, aphakic, or has a history of ocular surgery. Goniotomy is indicated in younger patients. Trabeculectomy has a drawback of aqueous leakage, macular edema, blood failure, and AGV, hypotony, tube blockage, and hyphema. Goniotomy is indicated in children. Thank you.
That was very well done on time, PPP squad.
Thank you.
We have Dr. Divakant Mishra who has joined us. Sir, are you here? Dr. Nupur ma'am, I can't see, sir. Can we move to the mentor comments then?
Yes, Arshi, please move.
All
Just
right.
keep a tab if he's there, then you can
Yes.
keep the comment.
So the team one mentor, Dr. Isha Sharma, we invite your comments, please, ma'am.
I think I'm not ma'am, but okay. Yeah, so I think I would like to congratulate YOSI first for, holding up with this iROCK session. And the PGs also, they've done an excellent job in a short time. Apart from that, I think on the topic per se, I would like to say the first and foremost thing is that you should identify the cause. I keep saying it on rounds, even during our clinics, that cause is the most important thing. Once you have it, the way forward becomes much easier. So, history taking and examination just to find that one etiology that you're treating makes it all, your way ahead becomes really smooth.
Thank you so much, Dr. Isha.
Thank you.
She's a glaucoma, she's a uveitis expert. And now I would like to invite our judges' comments and Q&A. Dr. Sati ma'am, questions from you, please.
Yeah. So going ahead with the comment by Dr. Isha, how would you try and figure out what is the mechanism that's working in a given patient in front of you?
Just
What
yeah, how they mentioned the four mechanisms. In the first one, say for example, we have, for example, if it's
Dr. Isha,
I'm
this is
asking-
for the teams, please.
oh, okay.
how do we identify what the mechanism might be in a given patient, in a patient of uveitis when you're examining? How would you try and determine the cause? And as Dr. Isha has mentioned, this is very critical and important because your management would directly be based on the cause.
Yes. Ma'am, first of all, on the basis of history, if the patient has had previous episodes and how they were treated. For example, the patient in our case we presented had a history of taking Acivir, which improved the symptoms. So here we can see that the etiology was viral. Other than that, we can have systemic associations such as inflammatory bowel disease or H. pylori or other.
No, sorry, I was not asking about the etiology for the uveitis. The mechanism for the glaucoma. What is the mechanism for the glaucoma in a given patient with uveitis? Not necessarily in the patient that you presented. In any patient, how will you go about trying to figure out what may be the cause?
Yes, ma'am. On examination, we could see if there is a pupillary membrane which is causing pupillary block, or if there is on gonioscopy, we could see peripheral anterior synecdoche or uveal effusion. Other than that, if the inflammation has been going on for months, we could suspect trabecular damage and posterior synecdoche on the lens by the iris, which can again cause pupillary glaucoma. Other than that, if the patient has been taking steroids for a long time, it can also be corticosteroid-induced glaucoma.
Yeah, so excellent. I think you've covered all the causes. What is important is to give importance to the history also. So oftentimes the patient comes to you when they have already received treatment elsewhere, like even in your patient, and then they come to you. So you need to try and see when the pressure started going up. Did the patient present with the uveitis along with the raised intraocular pressure, or did the patient present with normal pressures, was treated for the uveitis, and then started developing increased pressure, where it might then point to a steroid-induced mechanism? So each thing starting from the history onwards, your slit lamp examination, your gonioscopy, a shallow anterior chamber, the presence of a membrane in the pupillary area, the presence of iris bombae, the presence of uveal effusion, all these give you clues to the mechanism that may be involved. It's also important for us to remember that multiple mechanisms can be involved in a given eye. So it's not that there has to be only one mechanism, multiple mechanisms can be working. So once you try and figure out what may be the reason, then your management will depend based on the mechanism that is involved. Yeah.
Dr. Parul, ma'am, your question to the team, please.
Congratulations, Team PPP. Very well presented. My question to you is that everybody does not have the facility for a PCR. So, what factors will make you decide when to start an empirical antiviral therapy for your patient, oral one?
So, ma'am, we're talking about Posner-Schlossman here with the acute rise in IOP.
Not just the Posner-Schlossman, you mentioned herpes and CMV. So, any telltale signs which you may see clinically or any symptom that the patient may be presenting with, how would you decide that it's time to try an oral acyclovir for that matter?
Usually, viral uveitic glaucomas, ma'am, 50 to 90% have a raised IOP at the time of presentation. Other than that, we can have small nummular keratitis in varicella zoster and cape on the basis of keratic precipitates, such as in CMV, we have coin-shaped precipitates.
Any iris characteristics that you would like to look for?
Transillumination defects are common here. Segmental transillumination defects can be seen. And decreased corneal sensations can also be found in cases of viral keratouveitis.
Yes, so you look for patchy or sectoral iris atrophy pattern, and then you correlate it with a decreased corneal sensation, which may not be there in all the cases. But when you have signs of a herpetic keratouveitis or a manifestation on the iris, that would make you think on the lines of this. And once you have a response to oral acyclovir, based upon which major trial would you like to base your treatment, and for how long? Can you name some major trial or study which addresses this?
It is HEADS trials, ma'am.
This
Herpetic.
Titan 1 and Titan 2,
Yes,
which
ma'am.
talk about the management of oral antivirals. So have a look at it. But otherwise, wonderfully presented. Thank you.
Thank you so much, judges. Thank you, PPP squad. We will move on to the second team, the KY Jellies. KY Jellies, please start screen sharing. Their topic is angle recession glaucoma.
Just a minute, I'll reset the timer. Okay, ready to go.
Hi, am I audible?
You can
Yes, you're
start.
audible.
You can
All
start.
right, thank you. Very good afternoon to my esteemed judges, respected moderators, participants, and all my dear friends. Thank you for being here with us today. My name is Maggie. I will be presenting on behalf of KY Jelly's team regarding angle recession glaucoma. So angle recession glaucoma is nothing but a type of secondary open angle glaucoma caused by blood.
You're muted. KY Jellies, please unmute yourself.
Oh, sorry.
It's okay.
So why is this topic important? 60 to 100% of angle recession can be found after blunt trauma, especially if presented with hyphema. And around 4 to 10%, only a minority develop glaucoma, but the risk of this angle recession persists for years to decades. And more than 180 degrees of angle involvement, which is greater angle extent, is the classic high-risk signal that warrants tighter follow-up. So just a short recap on the impact to the progression to glaucoma. So what happens? First, you have the impact where there is an anterior-posterior compression of the globe, leading to the second, which is the expansion, where equatorial stretch places traction on the iris root and the ciliary body, which then have split happens where there is a tear between the longitudinal and circular ciliary muscle fibers, leading to the fourth, which is an acute rise in the intraocular pressure, whereby blood, debris, and inflammation injure the trabecular meshwork, leading to a late rise of intraocular pressure, where there is a scarring, sham canal dysfunction, and susceptibility, causing glaucoma. So how do you recognize that there is a angle recession going on? Trauma clues such as sphincteric tears, iridodialysis, hyphema, vosseous ring, or phacodonosis, and also gonoscopic clue where there is a widened ciliary body band compared with the fellow eye, and optic nerve damage, which gives rise to there is a visual field defect. So what happens actually in the anatomy? As you can see on the left, there is a normal angle where you have the shrubby line, trabecular meshwork, scleral spur, and also ciliary body band. But in the right side photo, you can see there is a widened ciliary body band compared to the normal eye. So how do we stratify the risk of this angle recession? Not all recession actually becomes glaucoma. So how do we have a surveillance based on the extent of recession, where more extensive recession beyond 180 or worse trauma or patient factors such as young patients can be lost to follow up. So we must follow these patients up regularly. So what are the differential diagnoses? Other differentials include steroid-induced glaucoma, UGHS syndrome, iridocorneal endothelial syndrome, pseudoexfoliation, or carotid cavernous sinus fistula, and also post-surgical glaucoma. So how is the natural history? It can be occurring from days to weeks, months, years, and also decades. And you can see that the eye can appears quiet, whereby the structural damage can actually still evolve and glaucoma can persist. So how do we work out? Based on the history, we ask about the mechanism, timing, prior trauma, steroid exposure, based on the examination using gonioscopy, intraocular pressure, looking at the structure of the disc, function where you check the HVF and also imaging. So what are our treatment principle? Medical first, we start aqueous suppressants such as beta blockers, carbonic anhydrase inhibitor, alpha agonists, and also PGA later, avoiding in the acute inflammatory phase, avoid pilocarpine and operate sooner when needed, especially when there's evidence of glaucoma occurring. What is genuinely new? There are some studies showing about the evidence of SLT and also angle surgery in this condition, but the effectiveness is still not is promising but not standard of care evidence yet. So incisional surgery can be also the treatment. We can opt for trabeculectomy with MMC, glaucoma drainage device, and cyclodestruction where poor visual potential is occurred. So how do we follow up the patient? First at acute trauma visit, and we see that the patient when the eye is quiet for a gonioscopy, and we stratify the risk for the patients and long-term follow-up, especially when patients are at high risk of glaucomatous damage. So take-home message, find it, check the patient using gonioscopy to make sure that's a recession, frame it, make sure that the angle recession is a structural scar, glaucoma is the delayed consequences, and follow up. That is all from me. Thank you.
That was very well done, the KY jellies. Can we invite your mentor, please? Sir, are you here? Dr. Y Yong Jing.
Yes, I'm here.
Hello.
Hi.
Your comments for the team, please.
So I think our team have presented this glaucoma topic. I have no additional comment on this. Sorry.
That's okay. So we'll move on to the judges' questions. I'll ask Dr. Vidya, madam, please, if you could ask questions to the team, followed by Dr. Manish, sir.
Hi, the QA Jellies, and hi, Y. That's a really good presentation. Congratulations. What I would like to ask is because a risk of glaucoma can still happen even after years. How do you, in this kind of patient, how would you like to proceed the long-term follow-up? What would your strategy and long-term follow-up in these patients?
So usually after the trauma, maybe at the 6 weeks of the presentation, we'll do a gonio and then see whether the patient have angle recession. And then after that, we'll follow up the patient in 2 to 3 months time, and then check the pressure regularly, and then we'll do the imaging as well, and also do a Humphrey visual field as a baseline. Then after that, if the condition it's already stable without any signs of glaucoma, then we'll be going yearly. However, if there is a presence of angle recession glaucoma, then depending on the intraocular pressure, we'll see whether the HVF is stable and then whether there's any progression. If there's none, then we'll follow up in yearly. If there is progression, then we'll follow up more frequent, maybe like 4 months to 6 months, like that.
Okay, thank you.
Dr. Manish, sir.
Yeah, thank you. Nice presentation, KY Jellies. Nice slides. So I have a question that in patients who develop angle recession glaucoma, they tend to have a higher chance of open angle glaucoma in other eye also. And there have been studies which have shown that. What could be the reason why a patient having trauma in one eye or angle recession glaucoma in one eye tend to have a higher risk of glaucoma in other eye. So other eye also needs to be kept under follow. Any idea?
Um, it could be
I think you mean the sympathizing eye, right? Developing glaucoma, sir.
The other eye, yeah. Not
Yeah,
actually you should
so
call a sympathizing eye, the other eye of the patient. Suppose.
okay. I think it can be due to few factors. One is it can be pre-existing genetic disposition, whereby the patient actually have some genetic predictability to get glaucoma in the future. Another is there can be also vulnerability, where the patient actually has some underlying trabecular meshwork dysfunction by itself, so leading to the other eye getting the glaucoma in the future.
Nice.
Mm.
So a lot of these patients are already predisposed to glaucoma, and the trauma and the scarring sort of aggravates the thing, and the patient develops glaucoma. So they do tend to have a higher chance in other eye. Thank you.
Thank you so much, sir. We'll move on to the next team now. Team Ora Serrata. Can you please share your presentation? So they'll be talking on anti-glaucoma medications. Timer, please, Dr. Prasanna.
Yes, Arshi. 1 second. Yes, full screen and then I'll start. Yeah, start.
All right. Time starts for you.
Good afternoon, everyone. So I'll be presenting on the topic anti-glaucoma medications. So as we all know, glaucoma is a silent thief of vision, and our jobs as doctors is to stop this step before it starts. Glaucoma is the second most common cause of blindness worldwide after cataract, and it affects nearly about 80 million people. And the sad part is that 50% people who have this disease are undiagnosed. This is exactly what glaucoma does to your vision, and you realize it before it's too late. So our aim of the treatment is not primarily just focused on the triad of raised intraocular pressure, visual field loss, or optic nerve damage, but it is also to achieve a quality of life for the patient by making the patient's current vision last out a lifetime. So a target intraocular pressure of less than 18 mm of Hg and 35% reduction in the intraocular pressure ensures that there are lower chances of progression of this disease. So these are all the anti-glaucoma medications that we'll be talking about in this session. First, the beta blockers. Beta blockers decrease the aqueous humor production by inhibiting the cyclic AMP pathway in the ciliary epithelium, and it causes 21 to 27% baseline decrease in the intraocular pressure. This decrease is initially more than 40% and it eventually fades out. The decrease in the intraocular pressure is 47% in the first week and 25% in the first year. The side effects of beta blockers are ocular, cardiovascular, pulmonary, neurological, and gastrointestinal. We have a lot of systemic side effects because beta blockers tends to get absorbed in the systemic circulation, and we often ask the patient to follow punctal occlusion so that systemic absorption can be reduced. The second are the prostaglandin analogs. They act on the prostaglandin FP and prostaglandin E receptors on the Schen's canal and trabecular meshwork, as you can see in the diagram, and it causes increased uvascleral outflow. Prostaglandin analogs cause 27 to 35% baseline decrease in the IOP, which is the maximum amongst the anti-glaucoma medications. The side effects of using prostaglandin analogs are hyperpigmentation of the eyelids, and this happens because of the increased activity of the tyrosine kinase enzyme. The second is the prostaglandin analog induced periorbitopathy. We can see in the first picture ptosis, and then the second picture there is there's an increase deepening of the upper lip sulcus. The third picture shows the hypertrichosis, and the fourth picture shows hyperpigmentation of the iris, which is permanent. The third are the carbonic anhydrase inhibitors. They block the carbonic anhydrase 2 enzyme in the ciliary epithelium, and the bicarbonate secretion decreases, and hence the aqueous humor production decreases. This are often used as managing the acute treatments. The side effects of carbonic anhydrase inhibitors are tingling sensation in the fingers and toes, kidney stones, hypokalemia, and metabolic acidosis. The corneal decompensation worsens, and hence these are avoided in people with Fuchs endothelial dystrophy, idiosyncratic bone marrow suppression, and it cross reacts with sulfonamide and hence is contraindicated in people with sulfonamide allergy. The fourth are the alpha agonists. They decrease the aqueous humor production by preventing the norepinephrine release at the presynaptic vessels. And the second mechanism is that they increase the uvoscleral drainage. Therefore, it reduces the intraocular pressure within 1 hour of installation. Alpha 2 agonists are usually contraindicated in children less than 2 years of age because they have a tendency to cross the blood brain barrier. The side effects include dry mouth, drowsiness, allergic conjunctivitis, rebound hypertension, and apnea in neonates. These are the pictures of the side effects showing iritis and including the KPs here. The next are the myotics. They act on M3 receptors and they cause ciliary muscle contraction, and the trabecular meshwork opens up and aqueous drains out freely. The side effects include brow ache, miosis, causing dim light night vision, and myopic shifts. The new FDA approved anti-glaucoma medications are the Rho kinase inhibitors, which were approved in 2017. They relax the trabecular meshwork, reduce resistance to aqueous outflow, and reduce the aqueous production. They regenerate the corneal endothelium, improve ocular blood flow, and are neuroprotective to the retinal ganglion cell. The side effects include conjunctival hyperemia, corneal verticillata, and subconjunctival hemorrhage. So this is a graphical representation of the percentage of intraocular pressure that is reduced, and the most common, most effective being the prostaglandin analogs. So, in order to achieve a proper treatment, we have to follow a proper treatment algorithm for anti-glaucoma medications. So, our aim is to begin low and slow. We have to start a monotherapy, minimize concentration and frequency, choose a drug which is more affordable, safe, is best suited to the patient's safety profile, and it causes the minimal inconvenience. So at last, I'd like to conclude by saying that don't let the silent thief of vision steal away your view. Thank you.
Very well presented and well in time. So I'll invite your mentor, Dr. Tithi Kundu, for her comments, please.
Hello, good afternoon, everyone. So, again, anti-glaucoma, she covered everything pretty from top to bottom. So, good job on that. This like anti-glaucoma medications are the mainstay of glaucoma treatment, and it's very important to know how each of them act, and especially with the side effects when we are prescribing them to patients. And yeah, that's all I have to say. We'll proceed with the next presentation.
Thank you, Dr. Tithi. So we'll invite our judges for the Q&A session now. Dr. Sati ma'am, your question to the team.
So we very well know about not giving beta blockers in patients with asthma. Would you also be careful with any other medications in a patient with severe asthma and stable asthma?
Beta blockers are basically contraindicated because
yes, so that is very commonly most people know about it. Any other drug that you would be careful with?
I might have to read about it.
So though bitoxolol is a selective beta blocker, it is just less riskier than a timolol. And so when you're giving bitoxolol also, you need to be careful. And if you feel that when the drug is introduced, there is a worsening of the asthma, then you may want to withdraw the medication. Similarly, though pilocarpine is not contraindicated, if it can increase the bronchial secretions, it can cause bronchoconstrictions. So again, be careful when you're giving pilocarpine, especially if the patient has unstable asthma, uncontrolled asthma, and if you notice that there's a worsening when you introduce the pilo, you may want to withdraw the medication. So this is something that we don't generally are aware of. We are very commonly aware with the beta blocker, but these two also you need to be careful with when you're prescribing. another quick, if you can just touch upon the point. So when you give instructions to the patients to use the medications, what do you tell them? And when the patient comes back, what all do you look for?
Ma'am, for lowering the systemic absorption of beta blockers, we often ask the patient to blink for about to just close their eyes for about 2 minutes, or we ask them to follow punctal occlusion so that the systemic absorption can be reduced and the systemic side effects can be looked upon on.
Yeah. So when you're prescribing the drug itself, make sure that the patient is made aware of possible side effects, because it is difficult for a patient to correlate why he or she is having a dry mouth when they've started some drops. So warn them about it, warn them about hypotension, warn them about all the possible side effects with each drug when you're prescribing. Put the timings down on your prescription. When you tell 2 times a day, the patient may be using it at 2 o'clock in the afternoon and 6 o'clock in the evening. So put all those instructions clearly, and like you told about punctal occlusion, how to instill the drops, all of that. And when the patient comes back for a review, it's not just looking at the intraocular pressure. You need to see whether the patient has developed any of the side effects. You look for any of the side effects in the eye and evaluate all of that. And if you do notice that there's any intolerance to the drug at any point, so usually this doesn't happen immediately, but later on when they come, when you're looking for this, if you do find that, make sure that you stop the medication. Continuing the drug along with a mild steroid, trying to control symptoms, will only make things worse. Conjunctiva will get inflamed, and even future surgeries can fail if the conjunctiva remains inflamed. Okay.
Dr. Vidya Anandita,
Okay.
if your questions to the team.
Congratulations for the presentation. As you already mentioned about the side effect of prostaglandin analog, but actually now we have a syndrome name for it. So can you tell me the name of the syndrome associated with the prostaglandin analog side effect? And then if your patient develop it, then what medication would you change your prostaglandin analog with?
Prostaglandin-associated periorbital.
And what medication would you choose if your patient developed PAPS?
Alternative therapy using another second-line drugs.
Any specific answer to that? A newer medication which is actually works. Yeah, more selective. Yeah, more selective than prostaglandin analog is omnidenapag isopropyl, or OMD, which works as selective EP2 agonist. It goes on with the brand name of Ibelis. So now it's actually what we can use aside from prostaglandin analog to achieve the same result. Okay.
Thank you.
Thank you, Dr. Vidya. Thank you, Team Aura Serrata. So we'll move on to the fourth team, Team Visionaries. Can you start your screen share, please? And they'll be presenting on the topic of glaucoma drainage devices.
1 second, Ashi. I'm resetting the timer. Yeah. Can we have the screen? Can we have the screen? Team Missionaries.
Dr. Surbi? Yeah. You have to move to the presentation.
Once your screen is in full share, I'll share the time. I'll start the timer.
Stop sharing, and when you reshare, select your presentation instead of the Zoom screen. Click share screen and your presentation. Good. Go to the full screen mode, slideshow.
Audible? Am I audible now?
Yeah,
Yes.
you're audible. Full screen mode.
Should I start?
Timer, please.
Is it
Full
in the full
screen
screen,
mode.
Archie? I'm not able to see it in the full screen.
Yes, I'll start. Yes, you can start.
Glaucoma drainage devices. So glaucoma drainage device, it is an implant which is placed inside the eye
Can
to
you
control.
move to the full screen mode, please? We'll pause your time.
Yes.
Share your slides like you did and just move to the slideshow mode. That's all.
Yes.
Yes.
But now
You can
also
move to the
full
slideshow.
screen. Can you click this button next to the -1 below? Right-hand side bottom, where you have the slideshow button.
Surbi, the slideshow, when you click on that, it moves on to a different window. So if you could just click the button on the bottom right of your screen,
Bottom.
right
There is-
adjacent to the zoom bar.
Yeah. Left. Slightly to your left, the minus, that
Yes,
one.
this one. Perfect.
Perfect. Have you clicked it? Do you have any videos in this PPT, Dr. Surbi?
Yes, sir. Yes, sir.
Oh, otherwise, we would have told you to go ahead with this.
Did you click on the slideshow? Because
Yes,
you
ma'am.
went through all of this in the trial run as well. All right. It's not opening in your slide, in your multiple windows panel. Can you see a separate slideshow window?
No, ma'am.
Stop sharing, restart again. Judges, we'll just give them a minute. If they aren't able to do it right now, we will move to the next presentation and come back to them.
Yeah.
Is
Yeah,
it
now it
visible?
is in full screen. Yeah, I'm starting your timer.
Okay. Good afternoon, everyone. Today I'm going to be talking about glaucoma drainage devices. So it's a small implant which is placed inside the eye, preferably in the supratemporal quadrant, consisting of a tube and a plate. The tube enters the anterior chamber, which allows a separate pathway for the aqueous drainage into the subconjunctival space. The physiology of a drainage device is via the fibrous capsule formation, which forms at around 4 to 6 weeks post implantation, creating a filtering bleb and allowing a channel for passive diffusion for the aqueous. The two key important factors which determine the final IOP are the thickness of the capsule and the surface area of the capsule. So why GDDs? So apart, the traditional indications of a GDD include the candidates who are at a high risk of trabeculectomy failure, like patients with prior conjunctival surgeries or cicatricial diseases, neovascular glaucoma, uveitic glaucoma, and other secondary refractive glaucomas like congenital glaucomas, eye syndrome, etc. GDDs can be classified on the basis of mechanism into valve GDDs and non-valve GDDs. Valve GDDs, they have the additional benefit of reducing the risk of hypotony in the early post-op period because they have a valve which opens up only after a certain level of IOP is reached inside the eye. The examples include Ahmed glaucoma valve and the Krupin implant. The non-valve GDDs, however, they provide a better IOP reduction, but they come at the cost of post-op hypotony. Examples include Bearwild, Molteno, Shockett, and Ahmed Clear Path. Other classification could be based on the basis of the reservoir material used to make the plate. So this is the comparative table between valved and non-valved implants. So talking about the non-valve devices, Molteno was the first modern and scientifically designed GDD. It is also the prototype drainage implant. There are multiple modifications of Molteno.
The Bearwilt implant, it comes in various sizes, 350, 250, and earlier a 500 millimeter square variant was also available. The most common one being 350. It is barium impregnated with multiple fenestrations. Talking about Ahmed glaucoma valve, which is the most common valved implant, uh, the mechanism of valve here is that there are two thin silicone elastomers which open only when a 12 mm of IOP is reached, which is the opening pressure for AGV. There are multiple models for AGV as well, most common being FP7 and FP8 and S3, which are the pediatric variants. The surgical technique for most of the GDDs are similar. The steps consist of conjunctival incision, followed by a dissection for the plate of the implant between the lateral and the superior rectus. The plate is sutured at around 10 mm from the limbus with a ninoproline suture, and the tube is cut with the bevel up. And 2 mm from the limbus, the tube is inserted inside the anterior chamber, keeping the parallel to the iris. So these are the surgical steps. I would like to talk about the four main important clinical trials in the first one being TVT, that is tube versus trabeculectomy. It was a multi-centric RCT which compared the efficacy of GDDs versus TRAB in previously failed GFS, which proved that tubes surgeries are better than a retrap surgery. Then ABC or the AVB trial, Ahmed Bearwilt comparison, and Ahmed versus Bearwilt trial. And the pooled analysis suggested that Ahmed had even though it had a lower risk of hypotony, but the failure rate was higher than Bearwilt. Complications. So complications of GDD include intraoperative complications like bleeding, tube misdirection, or aqueous leakage in case the port size is bigger than the tube diameter, or globe perforation, which can be seen in high myopes or patients with thin sclera. Early post-op complications include hypotony, elevated IOP or hypertensive phase, corneal decompensation, endophthalmitis, and other late complications are as mentioned. Recent advances in GDDs include ACP, Ahmed Clear Path, which is a non-valve device with flexible plate. It comes in two sizes, 250 and 350 square plate. ACP-ST is a smaller variant. It has a smaller lumen, thus providing improved flow resistance and pressure control. So GDDs represent the most frequently performed incisional glaucoma surgeries in the world today. And thank you.
Thank you so much, Team Visionaries. We'll invite your team mentor, Dr. Virinder Bagrania, for his comments.
Good afternoon, everybody. Am I audible, Dr. Asi? Am I audible?
Yes, you're audible.
Yes.
Yeah. Dr. Subir nicely covered all about GDDs in a structured and clinically relevant manner, especially the second last slides about new devices like ACP, ACP-STs. I think Dr. Issa's team's uveitic glaucoma case will come to us in few days for ACP-ST implantation. Thank you. Over to you, Dr. Asi.
Thank you, Dr. Virinder. Visionaries, if you could stop screen sharing, we'll invite the judges for the Q&A, please. Dr. Parul, ma'am, your questions to the team.
Well, congratulations, Team Visionaries. Beautiful presentation. Can you please tell me the difference between the TVT and the PTVT study?
Ma'am, TVT studies tube versus trab study, which studied the efficacy of trabeculectomy and Bearwilt implant in previously operated GFS patients. And PTVT is primary tube versus trab study, which compared Bearwilt and trabeculectomy with MMC in surgically naive eyes. So PTVT still suggests the use trabeculectomy as the primary incisional procedure. TVT, TVT basically suggests that tube is a better alternative in cases of a failed trab rather than going for a retrab surgery.
So, in terms of trabeculectomy as the primary procedure in PTVT, the lowering of IOP is better with trabeculectomy in the early part. But what about the safety and the complications that were mentioned? Was there any difference between the tube versus the trap group in PTVT? That's what I wanted to arrive at.
Ma'am, complications were seen more with the trap group, like overfiltering blebs or bleb leaks in the early, especially in the early post-op period.
Yes, that's right. And so, whenever we are informing our patients, we should be presenting to them all the valid choices because these days we are dealing with smart patients, so they are aware of all the options. So, present to them what are the choices in terms of the efficacy of the surgical procedure vis-a-vis the complications. But you've covered everything beautifully, and hats off to you.
Thank you.
Thank you, Dr. Parul, ma'am. Dr. Manish Singh, sir.
Thank you, Dr. Arshi. So nice presentation, visionaries, nice videos also. So one, two quick questions. You mentioned about hypertensive phases more common in the walled implant and less with the non-walled implant. Why is that so?
Sir, hypertensive phase is more common in valved implant. So hypertensive phase is because of a premature capsule, which is through which the aqueous diffusion is not occurring.
Okay.
And in a non-valved implant, there is free flow of aqueous even in the early post-op period, so it is less likely to cause a hypertensive phase.
It is something to do with the capsule, but initially you have more free flow in the walled implants because it is letting the aqueous go into the subcapsular space. So the capsule tends to be thicker and this aqueous is more pro-inflammatory. On the other hand, the non-walled implant, if you are aware, they're ligated for initial 1 to 1.5 months, so there is no flow of aqueous. So capsule is thinner, so you don't have more hypertensive phase in the walled ones compared to the non-walled ones. You've nicely covered the comparison. One observation I think you must be knowing that nowadays all the new implants which are coming, like the ACP you mentioned, the Paul implant, the RD implant which has come from India, all are amazing implants. These are all non-walled implants. And the only walled one is actually the Ahmed. Krupin, I don't think is available anywhere. So there is a trend to change towards more non-walled implant. If the walled ones are so good, why the non-walls are getting so popular nowadays?
So they are cheaper alternatives.
Maybe only RD is cheaper. The rest of them are comparable. Even Paul is probably a bit costly only. I think what you mentioned in about the ABP study and all, these non-walled ones tend to give you lower IP and better IP in the long run. So there is a gradual shift of using more and more non-walled one compared to the walled one. Yeah, but nice presentations. Thank you.
Thank you, Manish, sir. Thank you, Team Visionaries. So we'll move on to the fifth team, Team Vision Makers. Team Vision Makers will be presenting on trabeculectomy. Please start screen sharing, Vision Makers.
Yeah, your timer will start once your screen is visible.
Afzal, can you move on to your full screen mode?
Am I audible, ma'am?
Yes.
Yeah, yes, your timer has started.
Today's topic of discussion will be trabeculectomy. So this is the blueprint of trabeculectomy. It is the mainly a gold standard partial thickness scleral fistula for long-lasting IOP reduction. It was initially suggested by Sugar and was widely popularized by Cranes. The World Glaucoma Association recognizes it as the incisional procedure of choice in previously unoperated eye. Next. So these are basically the indications of performing TRAP. Patients having uncontrolled IOP despite maximum anti-glaucoma medications, documented progression of glaucomatous damage, poor medical compliance, and patient preferences. Whereas contraindications involve PL negative status, active ocular inflammation, extensive conjunctival scarring, and previous surgical scarring. Patients having biological risk factors like uh, active anterior segment neovascularizations, patient with Sturge-Weber syndrome, and phonic shortening with trachoma. This trap is generally performed in 1.5 mm blue zone map, which is bounded anteriorly by Descemet's membrane, whereas posteriorly it is marked by scleral spur and ciliary body initiation. Conjunctival flap design can be limbus-based flap or the fornix-based flap. In limbus-based flap, incision site is generally 8 mm posterior to the limbus and complications are less, and posteriorly directed bleb is formed which reduces astigmatism. Whereas in case of fornix-based flap, it gives excellent wide field visualization. There is lower risk of buttonholing and resurgery can be easily performed. This is the trap being performed in our center. 360-degree conjunctival paratomy being done, followed by scleral flap creation, and then application of mitomycin C antifibrotic agent. Is the scleral tunnel being formed, followed by peripheral iridotomy. Followed by suture and closuring of the wound site. This is the bleb which is formed after closure, which is diffused and vascularized. So these are the antifibrotic agents which being commonly used, being mitomycin C in concentration of 0.2 to 0.4 milligram per ml. It is applied for 2 to 3 minutes through merosyl sponge before creating the scleral flap. This is the ideal bleb. It should be pale and avascular. It should snugly fit to the upper eyelid for cosmetic region, and it should be shallow and diffuse. There should be rapid development of epithelial microcyst for active aqueous percolation. This bleb assessment can be done based on Indiana bleb appearance grading system and Moorfield's bleb grading system. This is based on bleb height, horizontal extent, vascularity, and Seidel test, whereas Moorfield's bleb grading system depends on diffusion area, height, and vascularity. If the target IOP is not achieved even after trap surgery, then we can advise the patient for digital massage. There is direct pressure to expand the subtenon's lake and clear anatomic obstruction, if any. If it is not controlled even after digital massaging, then laser suture lysis can be done. In case of failed or encapsulated bleb needling can be done. These are the Moorfield protocol of fibrotic risk stratification following trap surgery. In intermediate risk patients, we generally advise the patient for application of mitomycin C in lower concentration, whereas in high risk patients having neovascular glaucoma, chronic persistent uveitis, and aphakic glaucoma, mitomycin C application in a dose of 0.5 milligram per ml is advised. These are the complications of TRAP. It can be early or late. If the patient is having shallow AC along with the low IOP, then wound leak, excessive filtration, choroidal detachment will be the causes. In cases of high IOP with shallow AC, it is caused by pupillary block, aqueous misdirection syndrome, and suprachoroidal hemorrhage. In patients having deep AC with low IOP, overfiltration will be the cause, and in high IOP with deep AC, failing bleb will be the cause. Late complications include bleb leak, overhanging bleb, dysesthetic bleb, and blebitis. This is the filtration failure showing encapsulated bleb and late bleb necrosis. Certain vision threatening complication can also occur following trap, that is bleb related end-off, suprachoroidal hemorrhage, and wipeout or snuff phenomenon. So these are my references. Thank you so much.
Thank you so much. Team, you were very well in time and well covered. So we can invite your team mentor, Professor Colonel Alok Sati, sir.
Hi, hello.
Hello, sir.
Good afternoon, everyone. Very well presented. All aspects of surgery has been covered. Thank you, Yusikon. Best wishes.
Thank you, Alok, sir, for your comments. And we'll move on to the judges' comments now. Dr. Afzal, can you stop screen sharing? Dr. Sati, ma'am, questions from you for the team, please.
Excellent presentations from all the teams. Dr. Afzal, if you can just briefly give the main tips that you would like to ensure when you're doing a trap surgery to ensure good outcomes. Like you're doing trap surgery, so what are the main, like 3-4 key points that you would like to ensure during surgery?
Firstly, there should not be, firstly, in pre-op, we should advise the patient to stop certain medication which can affect the ocular surface, like prostaglandin analogs, and IOP has to be maintained prior to the trap surgery. That can be controlled using a Diamox, giving the patient Diamox or mannitol is also advisable. And we should make, and this scleral flap, performing this sclerostomy is the main step while doing trap. This has to be performed meticulously, and mainly our aim is to achieve hemostasis, and the formation of the bleb has to be diffused and vascularized. Our aim is our ultimate aim is to get diffused and vascularized bleb after performing trap.
You wouldn't want a very vascular bleb. So if you go from the beginning, careful or meticulous handling of the conjunctiva, meticulous handling of the mitomycin, ensure that the edges of the conjunctiva are not touched by the mitomycin, thorough irrigation after the use, ensure that your anterior chamber remains formed at the end of surgery. So when you do your scleral flap suturing, you check for the amount of filtration and make sure that your anterior chamber remains formed. If it is not remaining formed on the table, then it is quite likely that you'll end up with a shallow chamber in the postoperative period. And at the end of your conjunctival suturing, make sure that there is watertight closure of your conjunctival wound. Check with a fluorescent strip, check for a leak, and make sure that it is watertight closure. So these are the few things that you can ensure on the table to make sure that your postoperative period is a smooth sailing.
Thank you, Sati, ma'am. Dr. Parul, ma'am, your questions to the team, please.
When would you consider needling? At what would be the right time to suggest needling for the patient?
Bleb needling should be considered even if after performing trap and revision of the bleb, the IOP is not getting controlled, even after starting the patient on AGM, even after performing bleb revision. Or in case of encapsulated bleb, or even after failure of the bleb revision, then we will go for bleb needling.
So which features will you look for before considering the patient for a needling? Would you like to do any imaging or any investigation that would
Generally, ASOCT of the bleb is advisable before performing bleb needling.
So what would you see in that ASOCT?
There will be fibrosis and scarring of the of that site, of that bleb.
If
Bleb
it's
site.
totally flat and a totally scarred bleb, where
That is a failed bleb, ma'am. Then we can also.
Let me complete my sentence. If it's a totally flat, scarred bleb with scleral root not being patent, do you think that's going to succeed?
No, ma'am.
So a good way to ascertain that is to check the scleral root patency. You can do a UBM of the bleb that gives you a very good idea of the bleb health, sometimes even better than an ASOCT. So if you have a scleral root patent, the likelihood of success of a needling is going to be better than the one in which the scleral root is not patent. So the decision of needling has to be taken well in time. Is there anything that you can do during the post-operative period that can help prevent the hypertensive phase or the cytokine storm that comes around week 3 to week 6 post a trabeculectomy?
No, ma'am, I'm not aware, ma'am.
So there are some articles that talk about giving oral non-steroidal anti-inflammatory drugs, either ibuprofen or an indomethacin kind of a drug, which is given to prevent the cytokine storm that is much more prominent around week 3 to week 6. So if you have a patient wherein the bleb is very vascular and there is a tendency that it might develop into a Tenon's cyst, so if you start an indomethacin or an ibuprofen kind of a medication, that for a period of at least 2 to 3 weeks, that kind of makes the milieu more favorable for the bleb health. You can read this. There's a good article in Journal of Glaucoma about ibuprofen use to prevent failing blebs. Otherwise, very well covered in all the aspects.
Thank you, Dr. Parul. We'll move to the last team. Judges, please know this is team 6 for you. Team I got this. Please, could you start sharing your team? They'll be talking about lens-induced glaucoma.
Can you go to your first slide?
Hello, good afternoon, ma'am. Good afternoon, sir.
Yeah, your
Am I
slide,
visible?
You're
no,
visible. Your screen isn't.
yeah.
Now we're at the image
Is
of
it
two
visible?
eyes. Is this your first slide?
Yes, ma'am. This is my first slide.
All right, perfect.
Perfect.
So you
Yeah,
can
okay.
start the timer now.
Yes,
Start
ma'am.
with
Yes,
All
ma'am.
right. Please go ahead.
A very good afternoon, respected judges, teachers, and my colleagues. Today, I'll be presenting on lens-induced glaucoma, an important and preventable cause of secondary glaucoma and irreversible blindness, especially in developing countries where advanced cataracts are still frequently encountered. This topic is clinically significant because timely diagnosis and cataract extraction can completely reverse the disease process and preserve the vision. So, why is lens-induced glaucoma important? Lens-induced glaucoma represents a group of glaucomas that caused directly or indirectly by the pathological changes in the crystalline lens. Although modern cataract surgery has reduced its incidence in urban centers, it continues to remain a common in elderly patients with neglected cataracts, poor access to healthcare, and delayed presentation. The major concern being the prolonged elevation of IOP, leading to optic nerve damage and permanent vision loss. So, the permanent vision loss can really affect these patients and their lifestyle in general. So, the key components in these would be the lens pathology, increased IOP, inflammation, and the mechanism can be angle closure or open angle. So, this is a diagram depicting the angle of the anterior chamber. Now, to classify, there are basically two types, the open angle type or the closed angle type. The closed angle type consists of the phacomorphic glaucoma or the lens dislocation or subluxation. The open angle type consists of the phacolytic glaucoma, the lens particle glaucoma, or the phacoanaphylactic glaucoma. The pathophysiology basically includes the pupillary block, the trabecular meshwork obstruction, the lens protein leakage, the inflammatory cell reaction, along with secondary angle closure in some of the cases. So there are two theories, one of which states that as the lens ages, the stretching of lens capsule occurs, along with high molecular weight lens protein accumulating in the cortex. This proteins leak through the microscopic openings, which are phagocytized by the macrophages, leading to obstruction in the trabecular meshwork, gradually increasing the IOP. And the second theory saying the soluble lens protein theory, in which these proteins directly obstruct the tympanic membrane, causing an acute rise in IOP. So the first category we'll talk about is the phacolytic glaucoma. usually occurring in hypermature cataracts, in which there's leakage of lens protein and the macrophages blocking the trabecular meshwork. The clinical features we encounter are severe inflammation, a milky flare, floating white particles in the AC, and elevated IOP along with open angles on gonio. So this is a clinical presentation of the case. So as we said, it's usually mid-dilated fixed pupil, Morgagnian cataract, intact IOP, and retinal perivasculitis can occur due to leaking lens proteins. Now, this is an image depicting the phacolytic glaucoma with absorbed cortex. The second type being the phacotoxic or lens particle glaucoma. The pathogenesis behind this being the secondary open angle glaucoma, which is caused by the ruptured ALC. Predisposing factors usually are the trauma to the lens, following cataract surgery, spontaneous rupture of the capsule post-capsulotomy. The clinical features include there's acute pain, redness, and reduced vision, and there is always a recent history of trauma or surgery. So the pathophysiology being ruptured anterior lens capsule, leading to liberation of lens material into the AC, obstructing the trabecular meshwork, and the exposed lens material and inflammation further aggravating the IOP. The phacoantigenic or phacoanaphylactic type, in this, the hypersensitivity reaction, which is the Arthur's type reaction mediated by IgG and complement system, leads to the granulomatous inflammation, latent period being 1 to 14 days. Clinical features include circumcorneal congestion, KPs on endothelium, moderate cells and flare, residual lens material, synechial formation, low-grade vitritis, elevated IOP, and open angles on gonio. The pathophysiology being the disruption of lens. Is my PPT gone?
Yeah.
Your PPT just suddenly blanked out.
We'll pause the timer. Just you try to sort it out. Don't worry about the timing.
Hello?
Yeah.
Yes. Move to the slide where you left off. You're audible.
Oh, ma'am, I think. Ma'am, is the PCT? Yes, ma'am. I think there was an. Yes, ma'am. The network glitch occurred. Actually, the slideshow got closed.
Don't worry, doctor. You can resume.
You can
relax.
just resume.
Yeah, take a deep breath. Resume
Yes,
from
sir,
there.
I cannot hear. Yeah, ma'am, it's not.
Disha, it's okay.
It's fine. I have your slide. I can share. Can you just stop?
You can try once again, or else we will share it from our end.
Dr. Harshal, can you get ready with their presentation where they left off?
I'm ready only, ma'am.
Ma'am, Dr. Kang.
All right.
This side.
Doctor? Disha, are you facing some technical issues? Yeah, we can see you now. We can see your video. Harshal, can you start screen sharing? And Disha, you can just keep talking and you can ask Dr. Harshal to let him present the presentation, all right? Stop screen sharing.
Look. म्यूट करना पड़ेगा तुम्हें आई थिंक स्लाइड्स में नहीं हो रहा भाई क्या कचरा हो गया है
Dr. Disha, stop screen sharing, don't worry. You can just tell Dr. Harshal to move ahead with. Yeah, it's
Yes, ma'am,
okay, don't
because-
worry. We'll give you 15 seconds extra.
Ma'am,
Don't
there's a
worry.
major technical issue from my side.
Don't
fine.
worry.
You just
Yes,
stop
sir.
sharing.
Just stop sharing so we can start. And you just need to keep speaking the slides out, okay?
Yes, ma'am. Stop, ma'am.
Yeah. Harshal?
Yes, ma'am. Yes, ma'am. Yes, sir. Sir, can you
where do you
please
want to
shift
start?
to the phacoantigenic glaucoma?
Just tell me
two slides
where to
before.
stop.
2 slides before, sir. So just 2 slides before. So this is phacomorphic, just before this.
Here?
Yeah. Yes, sir. Yes, sir.
All right,
Yeah.
Disha, please start speaking.
Really
Just
sorry,
like-
everyone, for the technical error. So we were talking about the phacoantigenic glaucoma, and we discussed the clinical features, majorly emphasizing on the moderate cells and flare and the residual lens material seen in these cases, along with the synechial formation. So next. The pathophysiology, so there's a disruption of the lens capsule, leading to the antigens being circulated in the exposed in the circulation, recognized as foreign by the immune system, leading to inflammatory reaction, which leads to obstruction of the trabecular meshwork and raised IOP. So next. The second category beginning, the first one, which is the closed angle type, which is the phacomorphic glaucoma. So in these, the intermittent cataract is there, which leads to the forward push of the iris lens diaphragm, pupillary block, and angle closure. The clinical features being the lid edema, circumcorneal congestion, corneal edema, along with shallow AC with cells and flare. Peripheral anterior synecdoche can be present, a mid-dilated pupil with raised IOP and closed angles in the affected eye, and the fellow eye gonioscopy should be done to rule out any occludable angles. It is usually precipitated at night by pupillary dilation in dim light. The pathophysiology. As the lens ages, there is an increased antero-posterior length, leading to irido-lenticular contact, pupillary block, which pushes the iris forward. Irido-trabecular contact occurs, leading to secondary angle closure, which can be appositional or synechial. The predisposing factors in these cases will be the small hyperopic eyes, intermittent cataracts, traumatic cataracts, rapidly developing senile cataracts, zonular weakness, which is secondary to trauma or pseudoexfoliation, or any pre-existing narrow angles. The basic differentiation we should know should be between the phacomorphic and a case of primary acute angle closure, in which there is always a predilection, usually a predilection in PACG in females, and both angles have a shallow AC. And phacomorphic, there's only the affected eye which has the shallow AC. Now, the glaucoma associated with ectopia lentis. There are two types. One can be the subluxated lens, the other can be the
Disha, you should
dislocated
wrap
one.
up. You're already over time by
Yes,
almost
ma'am.
a minute.
Yes, ma'am. Yes, ma'am. The subluxated, there's partially displacement of the lens from the patellar fossa, and the dislocated, there's complete displacement from the patellar fossa. These are the systemic and the without the systemic associations where ectopia lentis occurs. This is a patient of Veal Marchesani. The management in case of subluxation, which is within the pupillary region, and no visual impairment is there, it is usually conservative, and the pupillary block, a laser PI should be done. Clinical presentation, as we've already discussed these features, these are the signs and symptoms the patient presents with. Diagnostic workup includes the visual acuity, slit lamp examination, tonometry, gonioscopy, and fundus. Investigation includes B-scan, UBM, and ASOCT. DDs include neovascular glaucoma, acute angle closure, uveitic glaucoma, or traumatic glaucoma. Primary management goals is to reduce the IOP, control inflammation, and relieve the pain. And the definitive is the cataract extraction. Initial medical therapy, we give the beta blockers, alpha antagonists, and the carbonic anhydrase inhibitors, along with hyperosmotic agents. Laser management usually done in case of phacomorphic glaucomas. A prophylactic laser PI is done. Surgical management is the definitive treatment. Phaco, SICS, or ECC is done depending on the case. Like corneal clarity, nuclear sclerosis has to be judged. Usually SICS is preferred out of all. The intraoperative challenges include the weak zonules, poor dilation, which can increase the chances of PCR and leaky lens material into the vitreous. Postoperative CME, persistent glaucoma, or corneal decompensation can occur. Prognostic good factors are if they present early, prompt surgery, and controlled IOP. Poor prognosis is delayed presentation. So to discuss a case, it's a 68-year-old male with a painful red eye, sudden vision loss. The diagnosis would be a
Dr.
phacomorphic
Disha, we'd
glaucoma.
respectfully ask you to stop.
Yeah.
You're over
Yes,
time by
ma'am. Yes,
almost
ma'am.
3 minutes, please. So we'll just ask you to go to your
Yeah,
summary
really
slide.
sorry. Yes, ma'am. That's it. Take home message. This is a summary slide.
Okay. Judges to note they were over time, but we will now, good job despite having a glitch in between. Can we invite your mentor, Dr. Abhishek Tripathi, sir, for his comment?
Hello, I'm audible to you?
Yes, sir.
So I really congratulate UC for providing residents such a beautiful platform of presenting their cases. And all the best. Just focus on the questions and answer them wisely. All the best. Thank you.
Thank you, sir. Thank you, sir. Good afternoon, sir.
Thank you so much, sir. And now we'll move on to the judges Q&A. Manish, sir, your question to the team, please.
Yeah, my question is, Dr. Disha, you were mentioning about patient with lens-induced glaucoma.
Yes,
So
sir.
suppose you have a patient with, say, phacoemorphic glaucoma and total
Yes, sir.
cataract. Pressures are around, say, 2022 with 3
Yes.
medications. You're planning a cataract surgery. So
Yes, sir.
what are the criterias? How you decide that you will just do cataract surgery, or maybe you will also consider going for a trabeculectomy along with that? So just I want to know on what basis you may think that maybe a glaucoma surgery also may be required for that patient. So any 2-3 tips you can share with us?
Good afternoon, sir. I think, sir, first of all, the examination of a fellow eye is really important in these cases. Like on the IOP, the AC depth of the fellow eye, along with the cup disc ratio of the fellow eye is important, sir, because the fundus examination and the cup disc ratio of the affected eye cannot be noted. So if that all of this is normal, sir, I would not think more in lines of the glaucoma surgery.
Anything about the duration of presentation? Maybe a patient who is presenting within a week
Yes, sir.
compared to a patient who is presenting
Yes,
after
sir.
a month.
Yes, sir.
Amount of synechia, or how
Yes,
many
sir.
medicine you need to control the pressure. Do you think these
Yes, sir.
things may
Yes,
decide?
sir.
Any role of ultrasound in assessing cupping? May not be accurate, but
Yes,
a
sir.
rough idea. Do you think
Yes.
these things can help?
Yes, sir. So if there's if I examine the patient and there's a prolonged history of increased IOP, and I see that it may be a case of, sir, closed angle closure or a pre-existing narrow, shallow AC, which is precipitating these conditions, and the amount of anti-glaucoma medications I prescribe the patient to lower the IOP to make him suitable for operation is also considered, sir. Like if multiple therapies had to be given along with the mannitols for 3 days, I would think on the lines of glaucoma. Along with that's a UBM, we can see any synecdoche, and we can see on ASOCT if any such thing is present, if there's completely edema and there's no corneal clarity that is present in these cases.
Thank you.
Thank you, sir.
Sir, any more questions from you?
No, fine.
Dr. Vidya, ma'am, your questions to the team, please.
Okay, congratulations for such a comprehensive presentation. In post cataract surgery, patients with suspicious of phacoantigenic or phacoanaphylaxis glaucoma, what examination would you do on those patients?
Good afternoon, ma'am. First, I would, ma'am, after post-op, I would see if the patient is presenting in between 1 to 14 days of surgery with any of those symptoms of redness, increased IOP, and a careful slit lamp examination to notice any kind of remnant lens materials or such things should be noted in these patients.
Anything more specific?
Ma'am, IOPs, the IOPs also should be evaluated. If there's a spike in IOP post-surgery, then we can things on the lines of any kind of injury that could have occurred and any kinds of leakage of lens protein that would have occurred. Any corneal edema, if we can see, ma'am, on examination.
I would also suggest apophyll deletions and also a gonioscopy in such patients, especially if you have corneal edema. Sometimes you will have lens material stuck like on the
At the angles.
At the angles, yeah.
Yes, ma'am.
Okay, thank you.
Yes, ma'am. Thank you, ma'am.
Thank you to all the judges. So this brings us to the end of the first round, which was the seminar presentations. Moving
you,
on to
ma'am.
the second round, Dr. Harshal.
Thank you, Dr. Ashi. That was a wonderful round. Now, moving on to next round, that is the pupils got talent. Here, the rules are the team members will collaborate and to a given presentation in the form of reel, music, or any interesting image with a theme as a glaucoma and 20 marks for each presentation or videos. Moving on to first video from team 1, the Prism, Pressures and PPP Squad.
Hi, I am Prednath. You must have heard about me and my friends, Moxie-D, Red Z, Innovate for skin allergies, steroid inhalers for asthma. I have such diverse uses in ophthalmology.
Oh no, my eyes are red. I got it. I've been using these lubricants since so long, but no relief.
You what I uses? That easier.
Cataract surgery post-op day 1.
For a wish, pennies and dimes for a kiss. I wasn't looking for this, but now you're in my way.
Cataract surgery post-op day 101.
Steroid use thus continues without medical advice, and what looked like simple relief starts increasing the pressure of the eye, resulting in glaucoma.
Wait, you steroid, because of you, I lost my vision. Stop. Here is my confession. I was created to help people. Doctors prescribed me as per need.
Despite my pure milky appearance, I do have some ill effects.
With prolonged use, steroids like meat increase the pressure inside some eyes. Over time, the increased pressure damages the optic nerve permanently, the structure which is responsible for vision.
You may experience narrowing of field of vision, which can cause difficulty in driving. Raised intraocular pressure can cause headache, eye pain, redness, halos around light, nausea, and vomiting.
Come on now, tell them who all are at risk for steroid-induced glaucoma.
Okay, the risk factors are family history of glaucoma, myopes, diabetes, children and elderly, previous steroid responder. Use me cautiously. Make sure to get regular IOP checks and use only with doctor's prescription. That's right.
Not every red eye needs steroid, but every steroid needs supervision. Stay aware, stay site safe.
Thank you, Team 1. That was a very informative video. I would like to take comments from our first judge, Dr. Sati ma'am.
Yeah, I think that was an excellent video and a very, very relevant topic. We see this day in and day out, and it breaks your heart when you see people who have been using eye drops for allergies, the children with allergic problems, the mothers see the relief that the child has and continues for 1 or 2 years and then comes with steroid-induced glaucoma or cataract. I think this is really relevant and an excellent message that really needs to go out into the world. And I think the sale of these steroid drops without prescription is something that probably needs to be stopped to at least reduce the burden of this disease. Thank you. Excellent video.
Thank you, Sati ma'am. Moving on to Team 2.
Hi.
The KY Jellies.
One day, we had a man who came to see us. He was found to be tripping in the clinic. He explained that he couldn't see the edges of the table and was having trouble in driving for almost 4 years. The condition seemed to worsen over the years. Hence, he was then referred to glaucoma consultant. After doing a thorough eye examination under the slit lamp, he was then sent for a visual field test to look for any visual field defects using the HVF machine. Sadly, the HVF results show an advanced glaucoma with tunnel vision. Vision loss in glaucoma can happen slowly without any symptoms. Once vision is lost from glaucoma, it cannot be reversed, but early detection and treatment can save the remaining vision. Get regular eye checks, especially if you are over 40, have diabetes, high pressure, or family history of glaucoma. Remember to always protect your sight. Screen for glaucoma early.
Thank you, Team KY Jellies. That was a very wonderful and informative video. I would like to invite Dr. Parul ma'am to comment on the video.
Well, congratulations, Team KY Jellies. It's very beautifully made and very wonderful. I think we can emphasize opportunistic screening of glaucoma with any ophthalmological complaint when the patient comes to us when they are over 40. But otherwise, very well made, and your point was very clear, which the patients would be able to understand. Awesome.
Thank you, ma'am. Moving on to Team 3. The team Ora Sereta.
Way too loud. I think I could have watched something
जो मैंने उसको समझाया कि देख you are not funny because you are not a comedian.
My God, what is this headache? Why can't I see anything? I think I'm gonna throw up.
नहीं कर सकती जो तू कर सकती है वो किसको करना है?
Hello, Sanskriti. I'm not fine. So please take me to a doctor right now. You will be fine. You'll see a doctor.
What happened to you? Why is your eye so red?
Doctor, she cannot see from her right eye and she has vomited thrice. Please look into it. What's wrong with her?
What happened? Did you put any drops in your eyes?
No, I was just watching a movie in my room and I started having vision loss and headache and I started throwing up. And I don't know what's wrong with me.
Was it a dimly lit room?
Yes.
Oh, now I see. That you were watching a movie in a dimly lit room that caused acute angle closure glaucoma.
Glaucoma? My father also has glaucoma. I never saw him having symptoms like this.
Glaucoma can present in different types. What she is having is an acute tract of angle closure glaucoma. When she sat in a dimly lit room, her pupils got dilated and angles got closed, which led to increase in her intraocular pressure. These symptoms can be managed using injectable medications aimed at lowering intraocular pressures, and surgical intervention, if required, can also be done.
Thank you, Team Ora Sereta. I would like to take comments from Dr. Vidya ma'am.
Congratulations, team, for making such a nice video. I can tell that you put a lot of efforts into it, and the awareness about acute glaucoma is actually what we need. And I think the video is very clear on showing the message that we want to give the patients. Thank you.
Thank you, ma'am. Moving on to next team, Team Visionaries.
Hi, doctor. I think something's wrong with my eyes. I'm able to see what's right in front of me, but I think I'm losing vision from the side. Yesterday only, I was crossing the road and I almost got hit by a car. Please help me.
Okay, calm down. Let me examine you first. the basis of investigations we have done today, I think you have glaucoma.
Glaucoma? What is that?
Glaucoma is a leading cause of blindness in India. It is known as silent thief of sight.
A clear fluid flows through anterior segment at front of the eye, nourishing tissues. At the open angle where the cornea and iris meet, the fluid flows through a spongy meshwork and leaves the eye. But if it passes through too slowly, the pressure inside the eye rises to a level that damages the optic nerve, resulting in vision loss due to open angle glaucoma. Untreated, the vision loss progresses from normal vision and no pain to gradual loss of peripheral or side vision and eventually a total vision loss.
Get your eyes screened today. If you have
age more than 40 years,
family history of glaucoma,
hypertension or diabetes,
high myopia or hyperopia,
history of long-term steroid use,
or any history of trauma.
Thank you, Team Visionaries. Very, very informative video. Moving, I would like to take comment from Dr. Manish, sir.
Nice video, and especially the animation was really good. It can be a very good video for increasing awareness about glaucoma in general among the population. So very good video. You should upload it on YouTube. It will be useful for everyone. Nice video.
Thank you, Manish, sir. Moving on to next team.
Hi, doctor.
Vision makers.
ग्लूकोमा क्या है? ग्लूकोमा हमारे आंख की एक ऐसी स्थिति है जहां आंख के अंदर का प्रेशर बढ़ जाता है। जैसे हमारे शरीर में ब्लड प्रेशर है, वैसे ही हमारी आंख के अंदर भी एकमात्र प्रेशर होता है। कभी अन्य कारणों से यह प्रेशर बढ़ जाता है और बढ़ के सामान्य से ऊपर हो जाता है। जब यह आंख का प्रेशर बढ़कर हमारे आंख की नसों पे प्रभावी होने लगे, इस वजह से हमारी परिधीय दृष्टि कम होनी शुरू हो जाती है और अगर आगे जाके इसका समय पर इलाज नहीं किया जाए तो अंधेपन की भी संभावना है। दो प्रकार के ग्लूकोमा होते हैं, एक ओपन एंगल ग्लूकोमा, दूसरा क्लोज एंगल या एंगल क्लोजर ग्लूकोमा। ओपन एंगल ग्लूकोमा यहाँ आंख के अंदर बनने वाले तरल पदार्थ की मात्रा बढ़ जाती है, मगर बाहर जाने की जल प्रणाली में कोई समस्या नहीं होती। एंगल क्लोजर ग्लूकोमा, इसमें तरल पदार्थ के बाहर जाने वाली जल प्रणाली काफी संकरा भाग हो जाती है और कुछ परिस्थितियों में पूर्ण तरह बंद हो जाती है। इस वजह से यह स्थिति कभी कभी इमरजेंसी के रूप में भी आती है, जिसमें आंख का प्रेशर अचानक ही काफी बढ़ जाता है। इसके साथ साथ आंखों का लाल होना, आंखों का दर्द, सर दर्द संभावित है। तो ग्लूकोमा से कौन कौन प्रभावित हो सकता है? सभी लोग जिनकी आयु 40 से ऊपर हो, उन्हें एक चेकअप के लिए जरूर जाना चाहिए। जिन्हों को ग्लूकोमा हो, मायोपिक यानी दूरदृष्टि दोष से पीड़ित, डायबिटिक एंड हाइपरटेंसिव, जो लोग स्टेरॉइड ट्रीटमेंट पे हैं और जिनको कभी पहले आंख में चोट लगी हो। ग्लूकोमा का इलाज कैसे किया जा सकता है? इसकी शुरुआत सबसे पहले रोग की जल्द से जल्द पहचान और निदान से होती है, क्योंकि एक बार नस के डैमेज हो जाने के बाद उसे ठीक नहीं किया जा सकता। ग्लूकोमा का मेडिकल ट्रीटमेंट आई ड्रॉप से होता है, जिससे आंख के प्रेशर को नीचे लाया जा सकता है। लेजर द्वारा भी आंख में एक नई जल प्रणाली बनाई जा सकती है। उन केसेस में जहां मेडिसिन या लेजर उपयोगी नहीं होता, वहां ग्लूकोमा सर्जरी करी जाती है।
Thank you, vision makers. I would like to suggest two tips, like whenever you make next time videos, just keep it in English subtitle, or better to have in English, so for our international audience also. Thank you. I would like to take comments from Dr. Sati ma'am.
Yeah, again, very nice video with all the information about glaucoma. Agreed, probably for a presentation here, it may be a bit of an issue, but this is excellent because a local language will have better reach to the general population. So as an educative video, I think this is really, really good.
Thank you, ma'am. Moving on to next team. Team I got this.
पापा, सब ठीक है?
हाँ बेटा सब ठीक है।
पापा क्या हुआ?
बेटा लगता है मुझे साइड में देखने में दिक्कत आ रही है।
अच्छा चलो आओ डॉक्टर के पास चलते हैं।
सर आपको सबलबाई की दिक्कत है, सबलबाई यानी ग्लोकोमा।
ये क्या होता है डॉक्टर?
ग्लोकोमा आँख की एक ऐसी परेशानी है जिसमें आँख का प्रेशर बढ़ने के कारण नस पे दबाव आने की वजह से आँखों की रोशनी धीरे धीरे कम होती है।
लेकिन मुझे तो कभी कुछ पता ही नहीं चला, इस चीज़ की दिक्कत भी नहीं हुई।
ऐसा ही होता है सबलबाई के पेशेंट्स के साथ। इसमें आंखों की रोशनी धीरे धीरे जाती है और इसे साइलेंट थीफ ऑफ साइट कहते हैं।
Thank you, team. I got this. I would like to take comments from Dr. Parul ma'am.
Well, congratulations, team. I got this. It was nice. It's nice that you used a regional language, but I think you could have covered some more aspects because essentially what you focused on was just the peripheral loss of vision. So some more aspects could have been added to it. But otherwise, a nice thought and a nice presentation.
Thank you, ma'am. I would like to take comments from Dr. Manish sir also.
I think all the videos were very nice. Nice message. One thing about the language, was it specified that the videos has to be in English only, or it was decided by the participants to choose any language? Because if it was specified that the videos has to be in English, then we'll judge in that way. Or if language was not specified, then the videos which are made in Hindi or local language definitely can have a bigger reach, especially considering the awareness part. What it specified initially that it has
So
to be in English
we
only?
had given them instructions as to the fact that it had to be something that the international judges could also understand. So either subtitles or the audio in English. So most of the teams who've used regional languages have used subtitles in English for that very reason.
Thank you.
Thank you, judges. I would like to hand over to Dr. Ashi ma'am.
And thank you so much, judges. This brings us to the end of the round 2. So the first 2 rounds were the ones that had to be judged on your Excel sheets. And we thank all of you and especially the team mentors also for being there for their teams. The teams have performed excellently so far. And I'm actually enjoying this process a lot along with you. Just to call it a wrap for the first 2 sessions, right before the judges, in case you want to leave and don't have some other commitments, we would love to have a group photo with you and also to distribute the certificates for your kind participation and all your feedback today. Dr. Vidya Dandita ma'am, Dr. Sati Devi ma'am, Dr. Manish Singh sir, and Dr. Parul Uchpujani ma'am. Sir, we will have a change on your certificate. Thank you. And now if we could have all the videos on and the compulsory YOSI, we would love to have a picture with all of you. Dr. Manjula ji, could you do the needful, please? Numeric Tech team?
Yes, doctor.
All right. Could we have a group picture?
Yes,
Could you
doctor.
stop screen sharing, Dr. Harshal, just for the picture? And
Parul
thanks
ma'am-
again to all our judges. It was
Parul ma'am,
amazing
Manish
having you
sir,
today.
requesting you to put the symbol. Yeah, Sati ma'am. Yeah.
Tati ma'am, Manish sir, Parul ma'am, Vidya ma'am.
We are also joined by
Taken, doctor.
some of the other members, Dr. Samita, Dr. Lippi. Thank you guys for joining and making all the preliminary sessions. Thanks to all the judges again for taking time on this wonderful afternoon and being there for young ophthalmologists and sharing your valuable inputs. And we all learned a lot from this insightful assembly.
And we'll be very happy to have you stay back with us. We're going to have a quiz and a jumble round for the teams now. And we'll move on to the quiz now. Dr. Prasanna, sir, please take over.
Yes.
We have
Yes,
the
yes.
timer ready for the teams. Teams, one single instruction right now. We just need one single login ID for all of you. Whoever has logged in from multiple devices, stop doing that. And we need all your faces on screen. However, only one of you gets to answer.
Thank you, Arshi. Arshal, with that, we'll move to round 3, which is again the much anticipated knowledge nexus quiz round. Next slide, Arshal. So in this, we can see that all teams will be playing together. One pre-decided team member among yourself. Please do pre-decide among yourself who will be attempting this round. Do not have multiple accounts. Will the team, the composition of this round is going to consist of 10 questions encompassing multiple specialities, and Dr. Arshal is doing the screen share as we speak. We will be giving you 20 seconds to respond in the chat box like a buzzer. If you know the answer, please do respond quicker and type the number allocated to them in the chat box. So we have the 7 teams. So PPP squad, you have a number allotted 1 to 7. You can see the KY Jellies, 2 Eagle Eyes. Of course, we are missing one team today. Type in the chat box only if you know the answer and have read the question carefully. That's very important because if asked to unmute, failure to answer within 10 seconds or wrong answer will give a -2. So again, I repeat, once you have responded your number code and when called to unmute, if you are not answering within 10 seconds or a wrong answer will give you a -2. Correct answer will fetch you a +2. Only one pre-decided member from the teams will type in the chat box using one device. And we will have 3 audience questions in between. To attempt, they have to type the alphabet I in the chat box. First, to type and then unmute an answer will fetch the audience a prize as well. I think with that, Arshal, shall we move to the next slide?
Yes, sir.
All the teams are ready. We wanted to have a trial question for you guys. So this is a trial question before we move to the rapid fire. So what is Charminar? So option A, Agra, option B, Delhi, option C, Mumbai, option D, Hyderabad. So the timer will start now. Arshi, can we have a sample
After timer, that team 5 has answered.
Okay.
Is D Hyderabad?
So once we say the timer starts now, you can, once the timer has started, you can start your answers. And Arshil, make a note of the responses.
Sure.
Which team has, and this is the answer. So Charminar.
Very well.
Hyderabad. So that is the trial question for you guys. So hope all the teams are ready. Is all the team ready, guys? Shall we move forward towards the main round? Yes.
Yes, sir.
Yes. So let's begin. Hope you guys are all ready. 3, 2, 1. Let's have the first question, Arshil. First question. All the following are true of laser iridotomy except A. Pre-treatment with apraclonidine prevents IOP spikes. B. Post-laser topical steroids are standard. C. Laser should be applied superiorly in the periphery. D. Hemorrhage may be induced by pressure from the contact lens. The timer starts now. Arshal,
Team 2.
Wait,
Team
Arshal.
2. Yeah.
Yeah, team 2. Arshal has called team 2. Where is team 2?
Team 2, KY Jellies, you can unmute and answer.
Harshal, I think is it team 5? 1 second. Is it team 5 that I can see?
Ma'am,
Just one
teams
second.
have to make sure that they type in their
Right.
names after we are done reading out the
Yeah,
questions that
reading
is
out the
told to
question.
them. So team 2 gets to go, ma'am.
Yeah, team 5 was
Okay.
slightly premature in typing. Yeah.
The answer is C.
Uh, sorry, your answer is wrong.
Sorry, team KY Jellies, your answer is wrong. The answer is D. Hemorrhage may be induced by pressure from contact lenses. Okay. So as Arshi had told, wait till we say timer starts now, and once the timer has started, start your instruction, or at least till we read the question, finish off reading a question. Okay. Arshi, you can make a note of that, and you
Yes.
can pick who's the right to wait till the question gets completed and starts the uh, typing. Okay, with that,
Yes.
Dr. Harshal, shall we move to the second
Yeah.
question?
Yes, sir.
Yes. Question 2. A patient presents for review 1 month post-trap for primary open-angle glaucoma. On examination, IOP is 4 millimeters of mercury and the anterior chamber is shallow. The bleb is cystic and avascular. The serial test shows sweating. What treatment option is most likely to be effective? A. Bleb needling. B. Autologous blood injection. C. Oral acetazolamide. D. 5-fluorouracil injection. Arshi, who was the first person to?
Team 5 now.
Team 5.
Okay. So both of you without any unanimously team 5. Team 5, can you answer the question?
It's B, autologous blood injection.
Okay, let's see whether that's the right answer, Harshal.
Yeah,
Yes.
it's right.
Yeah, you are right, team 5. You get the point. Autologous blood injection is the right answer for this question. Moving on to the next question.
Audience.
Yeah, audience, if you guys are interested, or even any one of you participating in the Zoom, over to the next slide, Arshal. Which structure drains into the middle meatus? Maxillary sinus, nasolacrimal duct, sphenoid sinus, or the posterior ethmoidal sinus? Audience, this is for you to answer, or if the teams are also participating in it, yeah, you have to type I. That's fine.
Akshika. Dr. Akshika, you can.
Sir, it's B, nasolacrimal duct.
Sorry, that was the wrong answer.
No.
Okay, that
That's
was
only
wrong
after the
answer.
DCR surgery. Until then, it's the inferior meatus.
Our quiz master Arshal has declared that it's a wrong answer. So unfortunately, but you don't lose marks because this is an audience response question. So moving on to another round of seriousness, Arshal, can we have the next slide?
Yes,
Question
sir.
3. Recurrence of the original disease process has been reported following penetrating keratoplasty for each of the following conditions except A. Lattice dystrophy, B. Herpes simplex keratitis, C. Rees-Buckler's dystrophy, or D. Fuchs dystrophy.
Team 2, I guess.
Team 2.
Yeah, team 2. Team 2.
Okay. You can unmute and answer.
Hello, the answer is donkey.
Fuchs dystrophy.
Answer is?
Okay.
Yeah. Perfect.
Yeah, it was the right answer.
Team KY Jellies, you got it right. That is the right answer. Fuchs dystrophy is the right answer for this condition. Congratulations. Moving on to the next question. Question 4. The CT examination shown in the figure is from a 62-year-old man. Which of the following is least likely in the differential diagnosis? A. Fibrous dysplasia, B. Metastatic melanoma, C. Metastatic prostate carcinoma, or D. Sphenoid wing meningioma.
Team 4.
Five,
4.
Arshi. I
Team
cannot.
5. Team 5.
Five.
So it's B, metastatic melanoma.
Metastatic melanoma B. Let's check whether it's the right answer. It is the right answer. Team 5, Dr. Afzal, Vision Makers, you get it. That point is yours. Congratulations. With that, let's move to question number 5, Arshal. Shall we go for the next question? Yes.
Yes, sir.
So, one request to the team, wait till the announcement is done, till the option D, and then click the buzzer. So our co-quiz masters, Arshal and Arshi, are making a clear note of it. so that even if you know the answer, please make sure you click the buzzer at the right time. Yes. So with that instruction, I'm going to read it out. Wait till I'm completing and then click the buzzer. Q5. Which of the following concerning Horner syndrome is true? The distribution of anhidrosis does not help in localizing the lesion. Option A. Option B. Cocaine 4% will dilate the pupil of the patient with Horner syndrome, whereas it will leave a normal pupil unchanged. Option C. The evaluation of a patient whose myotic pupil does not dilate with topical cocaine, but does dilate with topical hydroxamphetamine consists in part of chest X-ray and careful neurological examination. And the last option D, Horner syndrome with coincident ipsilateral headache is benign and requires no further neuroimaging.
Team 5.
Team 5.
Ma'am, it's C. The evaluation of a patient whose myotic pupil does not dilate with topical cocaine, but does dilate with topical hydroxyamphetamine consists.
That's right answer.
That's wonderful, Team 5. You have got the right answer for this question. Many congrats. With that, moving on to the next slide. Question 6. Identify the malignancy. A. Malignant melanoma. B. Squamous cell carcinoma. C. Sebaceous adenocarcinoma. Or D. Basal cell carcinoma.
I think team 1 and 4 were kind of like I think team 4 gets it.
Team 4, Arshi,
Team
team
4.
4.
Team 4.
Yeah.
I think
Option
the
B.
chief quizmaster has intervened due to a tie
Option
and
B.
told it's Team 4. Yeah.
Okay, wrong answer.
Wrong answer. Unfortunately, your swiftness in pressing the button was not equivalent to the correctness of the answer, unfortunately. So, apologies for that.
These are keratin pearls that you see here, which are seen in
yeah,
squamous cell carcinoma.
yeah.
Sir, we selected the option B only.
B or
I
D
said
you
B. Yeah.
So, in case of this, Nupur ma'am, Arshi, your
So
decision
next
is
time we
final.
want you to read out the option also, not just say A, B, C, D, because B and D can be very confusing. So I think we can give it to them. Okay, but
We'll check
next
out
time,
the video also, but yeah, sure. Yes.
yeah, we'll cross check this during the YouTube and we'll get back on this. But till then, you mark it for them. But next time, the teams have to say the entire thing. And Arshal, don't be very quick on changing the slides. Just hold on, okay?
Yes, sir.
When
Just hold on.
when Prasanna is ready to read the question, only then you flash the question. Because once a question is flashed, then they get a lot of time to search.
I just want to give an input. Like I was listening to this, they did select B only. Like I heard it as B.
B or
So
B for bat or D for dog?
B for bat. They said B for bat.
They said the
The
correct
team.
thing. Okay.
Yeah,
But then
they
we
said
want you to say but we want the teams to read out the entire
I
thing.
think that would be
So
better.
I shall be be a little slow in changing the slides. Okay. Don't be in a rush to. Yes. Let's clarify what they are saying and then. So now when Prasanna says he's ready to read out the question, only then you flash the question.
Thank you.
Yeah.
Thank you,
Yeah.
Nupur ma'am, for again your guidance whenever we face a hurdle, and ma'am's decision is final. With that, moving to the audience question. We have the audience question now. AQ2. Sunflower cataract is seen in galactosemia, Wilson's disease, chalcosis, or D. atopic dermatitis.
Shazia RB.
Put in the chat box.
Option B, Wilson's disease.
Okay. Option B, Wilson's disease. The answer is unfortunately a wrong one. The correct answer is chalcosis. Sunflower cataract is seen in chalcosis. Right. Arshal?
Excuse me, sir. Sir, in our screen, for the last question, team 1, sir, it is coming before 4. Team 4. Is there some other criteria you are...
So the criteria is that once they read out the option D, only then whoever presses the buzzer is being considered. So you have to
We did press after that only.
no. So because I typed in XXX after
Yes,
the.
it is coming after that only in my chat.
So in my chat box, it's coming 4.
Yeah, my chat also
Yeah.
4 is coming
If you
before
want,
1.
we can share the screenshot on the group as well.
No, okay, ma'am.
Yeah.
Dr. PPP squad, really unfortunate, but still the judge's decision is final and binding.
Yes, sir.
Keep trying for the best. We still have many more questions. Wishing you the best.
Do you, Prasanna, do you want to keep the thing as, till you read out the last option, or let them just press and then whatever you say?
Soon after the flash, ma'am, flash of the
Soon
screen.
after the flash, let them,
Ma'am,
and then within 20 seconds they have to answer.
Ma'am, since we have followed this template, shall we complete it in this?
Yeah, just do it. Yes, you can do
Yeah,
that.
you have
No
to be
problem.
the fast listeners as well, dear all. Be the fast listeners, fast fingers. So we are testing all your cognitive skills here on the last Sunday of this prelims iROCK. So be the fast listeners, fast pressers. Wait till we complete reading and then click it. So since we followed the same template for the previous one, we'll go ahead with this. We got the permission of Madam as well, Nupur ma'am. With that, Harshal, can we have the next slide? Right.
Yes, sir.
A child with retinoblastoma is born to healthy parents with no family history of retinoblastoma. The chance of retinoblastoma occurring in a second child is approximately option A 5%, option B 25%, option C 40%, or option D 50%.
So for me, Arshi, it's coming team 6.
For me also it is
Team
6.
6.
Yes.
Ma'am, it is A 5%.
Okay, let's see whether it's right. It is the right answer, team. I got this. You got this right. So you got it right. So wonderful. With that, shall we move to the next question, Harshal? Yeah.
Yes, sir.
Name the world's first clinical stage bimanual ophthalmology robot which successfully completed the retinal surgery. Option A, Sophia. Option B, Apollo. Option C, Luca. Or option D, Shaky.
Team 2.
Yes, for me also it's coming as
Hi.
team
Hello, it's C, Luca.
Luca. Let's check with Dr. Harshal. Yes, it is Dr. Luca. Many congrats again, team iJellies, all the way from Malaysia, getting it right. So let's move to the penultimate question, question 9. What is the probable diagnosis? A. Behcet's, B. Serpiginous choroiditis, C. Birdshot retinochoroidopathy, or D. VKH?
Team 2 again.
Okay.
Nupuma, you've written XXX after. Do you want to just recheck?
I thought it was team 1 after, but you take the call. It's okay. I wrote it as soon as he read out D.
Harshal?
Ma'am, I think team 2 only.
Team 2.
Team
Good.
2.
Team 2.
Team
Team
2.
2. Team 2, ma'am. I'm also going with 2. That's
Yeah.
what's coming in my chat also.
Hmm.
Team 2.
Team 2?
From the Starry Sky.
What?
Team 2.
Hi.
Go for it.
Yeah, team 2. The answer is Donkey BKH.
Can you repeat it once again, team 2?
They said
They said
VKH.
DBKH.
VKH. Okay. Arshal, can we check whether that is the right answer? Many congrats. Once again, you have got it right. With that, Harshal, can we have the next slide?
Last question.
Vertical prism test measures what? A. Tropia. B. Phoria. C. Fixation preference. Or D. DVD.
Team 4.
Team
Team
4.
4.
Yeah. For me also team 4. Yes.
D DVD.
B.
Okay. Can you
They
repeat
said
it
D
once
DVD. DVD.
Okay.
Okay, let's see whether that is the right answer. Unfortunately, team 4, that is the wrong answer. The right answer is vertical prism test measures fixation preference. So with that, we come to 10 questions. Do we have an audience question, Arshil?
Yeah.
Yes.
Fantastic. So we have one more audience question to wrap up the quiz segment. The audience question is, next slide. Okay, Arshil. Yeah. AQ3, most common complication of traumatic ifema is A, cataract, B, glaucoma. Wait for it, Dr. Madhur. You have to click after you finish D. Okay, wait for it once again. C, corneal blood staining, or D, rebleed. I think Nilesh has entered.
Dr. Madhur Harsolia.
No, I think, okay. But Madhur, I think, entered, but Nilesh entered correctly, I believe.
No, I am out of the question. I'm not allowed.
Okay, then you can ask Dr. Shweta Sri Rajashekar.
Yeah, because I gave Madhur an opportunity to actually, I told her specifically to enter again, but somehow I think she missed it. So Nilesh has forfeited to the next person. So Dr. Shweta
rebleed.
Sri Rajashekar,
Sir, rebleed. Option D, rebleed, sir.
Option D, rebleed. Okay. Dr. Arshal? Yes, so that is the right answer, Dr. Shweta. So you are crorepati now.
Shweta, we request you to please share your details on the chat box so we can reach
So
out to you later for your
Archie
award.
will share you your due credit.
Big award.
Big award.
Nupur ma'am is going to share.
Yeah. Anyway,
No, we would want you all to come to YOSICon and
collect your check.
Yes. We'll try to, we can work that out. We can discuss.
On a lighter note, that was. So we'll get back to you with the awards, which will be announced by the team leads as well as the GC and the team leads very soon. Nupur ma'am and Dr. Nilesh is also here. So with that, I think we have come to the last segment of the final segment, which we are all
Prasanna,
waiting
before we move on, I think we'll just do the group photo since I think a lot of people have already joined.
Okay.
Yeah. So just Harshal, can you just stop sharing the screen? So teams, we'll just hold on you for 5 more minutes before you move on to the last round. So as we said earlier that, today is the last prelim session of this 2-year journey of this iROCK team. And it's a very, very special moment for us. Most of the iROCK team has joined. We have from GC, we have Dr. Nilesh and Dr. Prasanna, and I think it's Dr. Madhur is here, who was one of the iROCK finalists from last year. Such a pleasure. Akshika, I could see here, she was also one of the participants, and she's been doing fantastic. So maybe just one minute of quick few words from the team members, quick about your journey, and we can take a quick group photograph, and then you can just move on to the unscramble segment. We can start with, I think, Nilesh first. We'll start with our secretary. Quick, few words.
Thank you so much, ma'am. Again, it's a great pleasure that the second season also ended flawlessly. Like not even a single glitch throughout the second season, as well as it was the thing in the first season. And the entire team is here. I think the smile says it all. That everybody is smiling. And that is not a sigh of relief ki khatm ho gaya. They are all happy that it went very, very well. So kudos to all. And please, ma'am, let's move ahead with other comments as well.
Yeah. Prasanna, your comments.
Thank you, ma'am. Again, it's your vision. Of course, Diva sir, you have started this iROCK initiative, and I think you saw the vision that it has to go global this year. And despite multiple commitments, ma'am is having a lot of babies in YOSI and socio-cultural, to name a few, and a lot of other events. And I think iROCK has also been born, and it is rocking it with a bang, because this year the idea was to go international, and Nupur ma'am saw it, and I think, as she always say, the team was able to execute it, because I think we have covered almost 10 countries in this, judges and teams together: Malaysia, Sri Lanka, Philippines, Indonesia, many countries, if I'm missing out on any other countries. And I think the culmination of it is going to be at the International YOSICon, July 10 to 12. And I think thank you, ma'am, for giving me also an opportunity to be part of the team and conduct the event. I think it's been an absolute pleasure. Thank you.
Thank you. Samita, you're there. Your thoughts on the entire iROCK.
Hi, Nupur. Thank you so much for, making all of us join to this last prelims. I think this is something different from what we did last time. And it's so nice to see that we have, completed 2 years of this iROCK. I can't believe it. It just feels like we started yesterday. And this is the best team I've worked with. It's all inclusive and there is so much positivity. And everybody's just contributing in the positive to this team. And it's very nice to see that everyone has a same mindset, and we are all about encouraging the youngsters and our postgraduates and residents to do more. And they're fantastic, and I've learned so much from iROCK, seeing the questions and making the questions. So absolutely amazing group and an amazing event. So hats off to you, Nupur, and thanks to Divakant for coming up with this concept, and to many more years of iROCK.
Thank you.
Thank you.
Lippy, thank you. Lippy, your thoughts?
Good evening, ma'am. I think this was one of the brilliant ideas by Nupur ma'am. As we say, she's always bubbling with new innovative ideas, and iROCK was one of them. Thank you, ma'am, for making me a part of this wonderful team. And I was following this episode as well on YouTube. And all the participants were really amazing. They did amazing entire iROCK team for this wonderful coordination. Thank you.
Thank you, Arshi. So just a correction. So this was actually a brainchild of Dr. Divakant. We just sort of executed this. So yeah, Nilesh, I think, is saying something. He's talking to someone else.
Yes, just traveling in the middle of travel.
Yeah,
As important as the creative courtesy, ma'am. Execution is.
No, I think it is the brainchild of Dr. Divakant, but you are the face of iROCK, Nupur, I think.
No, I think we all are, because it's not possible for one or two people, to have 4 Sundays in this season, 11 Sundays in the last season. It's just impossible. I think it's just the way the entire team works like a clockwork. So I would like to, this is an opportunity for all the participants also, that tomorrow we would like to see you as executives, once you are on the other side, to have a similar team spirit and work like this. So I think iROCK team is an example of how a team should work. Despite sometimes I do lose my cool and say a few harsh things, but all of them,
No. We
take
need
it in
that
the right.
push. We need that push,
Right.
otherwise it becomes complacent. So we are
Mummy
thankful
ki
for it.
dant.
Yeah, Arshi, few words from you. Yeah.
It's been an amazing team to work with. Thank you, Nupur ma'am. We've learned a lot from how to, and how to lead a team also from you. And Divakant sir came up with an excellent concept. It's been amazing seeing how the teams have also grown. I know I've learned a lot in every session that I've been part of. And it's improved our camaraderie. I've made a lot of friends because of this. And also, it's amazing seeing how creative the residents are, how much hard work they're willing to put in. It kind of just gives us a boost as well. And I'm sure that you all get to learn from each other. The main thing is that the residents get to connect, they get to understand. It's all learning, it's competitive, sure, but you all get to learn from each other. And it's gone international now. I think it's just, gonna take up really high in the future as well. Thank you, ma'am, for having me.
Thank you. Arshil, yeah. Few
I
words from
just
you.
want to thank everyone. Like, it was a new concept for us. The moment we joined, like 2 years back, it was very new. We also get to read about for questions and all. Then, like, it was a great learning, not only for you people, like participants, but for us also, like mingling and all. Get to know each other. This team is very good. Thank you, Nupur ma'am, for giving us such opportunity. Yes, Samita ma'am has rightly said that the concept was maybe of Divyakan sir, but the face is all you only. Especially like
No,
we were
it's
very
all of
scared
us
about.
together.
We are very scared of your dart and all. Yeah, that's why we do, ma'am. But thank you for guiding us every time.
Thank you. So I think not to delay further, we'll take a quick group photograph so that you can move on because the participants are also waiting. So we can just, Prasanna, can you take her if Manjula ji is there? We can just ask her to.
Yes, ma'am.
I'll take
Manjula ma'am, yeah, can you take a picture, ma'am?
I'll take doctor.
Done, Manjula ji?
Yes, doctor.
Yes, thank you. So I think I'm going to miss these Sundays 2 to 4, finish your lunch quickly so that we can start the session. Yes, I think it's been a wonderful, wonderful journey. And of course, it's not the end. We still have the YOSI finale, and we look forward to welcoming all of you. Over to you,
Yes.
Prasanna, Harshal, and
Yes, ma'am.
Arshi.
Yeah, all the best to all the
Yes,
participants.
all the best.
Thank you.
Yes,
Thank you,
thank
Sam.
you. Thank you. Sorry for wasting.
Thank you, Sam. Thank you, Lippy, for joining. With that, I would like to hand over round 4 to Arshal again, Arshal and Arshi, for the wordsmith war and scramble. Over to you guys.
Thank you, sir. Thank you. Moving on to round 4, that is wordsmith war and scramble. The rules are each team will play one by one, and one pre-decided team member will play for the round. 6 jumbled words will flash on screen, and time to solve is just 1 minute. So 1 mark for each correct answer. One by one, each team you can discuss, but only one team you need to tell. We can take a trial round. Anyone of you want to trial? Anyone of your team? Please unmute and answer. Any team?
Sir, apple, orange,
Yeah.
strawberry, and
Yeah.
pineapple.
Yeah, correct. Thank you. We will have a stopwatch for 1 minute for each round. Okay. Arshi, you are taking care of like stopwatch, right?
Yes, I will.
Yeah. Let's begin. Team 1.
Gonioscopy,
Yeah.
gonioscopy, biometry.
So first is gonioscopy,
Yeah.
third biometry.
Continue. Okay.
Pachymetry,
Okay.
Good. Second pattern.
You're right.
anisocoria,
You're right.
fourth.
Too many.
Yeah, 15 seconds.
Entropion,
Yeah,
6.
right. Okay. You have answered 4. You have answered actually 5. Last endophthalmic you couldn't answer. So 5 marks for team 1.
Yes.
Moving on to next team 2. Arshi, you are ready?
Yes.
Time? Yeah.
Team 2, unmute.
Yes.
Ptosis, fingicula,
Yeah.
Nystagmus.
Yes, right. Next.
Acropion.
One. What?
Hemianopia.
Right.
Scotoma.
Right. Last one.
Ectropion.
What?
Nystagmus. Nystagmus.
We are not going to give them the last one. That was after time.
Yeah.
Oh,
I can say they have told 5 out of 6. That ectropion you said after timer.
We say Ectropion before. Yeah.
Nystagmus was after time.
Okay.
Ectropion was before time. So they get 5.
Yes.
Okay.
Team 3, please be ready. Arshi, ready.
Yes.
Team 3, please unmute.
Yes, sir. Pterygium,
Yeah.
amblyopia,
Yes.
photophobia.
Your voice is breaking. What was that?
Last one.
Last one.
So photophobia.
Okay.
Yes, sir.
Next.
And floaters.
Okay. Next.
So the second one is it's keratoconus.
Right.
And then papilledema.
Okay. Yeah.
Time's up.
Yeah. They answered everything. 6 out of 6.
Yes. So they got L6.
Yeah. Congratulations, Team 3. Team 4, be ready. Arshi, timer.
Yes.
Meiosis.
Please unmute.
Fifth
Yeah.
meiosis, cycloplegic. Fifth meiosis and
Okay.
third cycloplegic है नहीं
Okay.
एपिफोरा फर्स्ट इज एपिफोरा हाँ
Okay.
fourth midriasis
meiosis,
Okay.
fifth meiosis
exophthalmos,
Okay.
sixth exophthalmos
Okay. Right. One is remaining.
How many have we got?
first वाला
One.
first वाला
Second, epifora.
first epiphora हाँ हाँ
Yeah. Right. You need to tell second one.
second one pterygium
They got 5, right?
Yeah. They got 5. Retinoscopy it was. Very well done, Team 4. Next, Team 5, Vision Maker, please be ready.
Time
Unmute
starts.
yourself.
Team 5, we can't see you. If you can't see you, we're not going to mark you.
I'm Calazion.
Yeah.
Dacrocystitis.
Okay.
Hordeolum.
Okay.
Blepharospasm. Blepharospasm. Ophthalmia. Dacrocystitis.
You said already. 3 is remaining. First, fifth, and sixth.
10 seconds.
Symblepharon.
Okay.
Inophthalmos. Inophthalmos.
Okay. Yeah. Last,
Time's
six.
up.
Ophthalmia.
Time's up. They get
Out
5.
of, yeah, anophthalmia.
Said an
Team
ophthalmia.
six, you said
Yeah, you got it
ophthalmia.
after time, so we're not going to give you the last one. We're going to give you 5.
I said inophthalmos and anophthalmia also.
But that you said after timer,
You
1
said
minute.
it after the time was up, Peter.
Okay, moving on to team 6, our last team. I got this. Be ready. Timer starts now. Please unmute and show your face.
I
Team
got
6,
this. You're not going to
I
mark
got
you
this.
without seeing your faces. Can we get your faces there? I got this. Are you there?
Hello?
Yeah.
Yeah, please answer fast.
Hello? Oculoplasty, hyphema,
Okay.
hypopion,
Okay.
coma,
What? What?
coloboma, sir, coloboma,
Okay. Nice.
xanthelasma,
Okay. First one is remaining.
buphthalmos.
Yeah, right. Congratulations, team 6. I got this.
Thank you, sir.
By 6. 6 out of 6.
Thank you.
All right. So they got all. So I think they got
Yeah.
all. Yeah.
All 6.
Yeah.
Team Eagle. Anyone wants to try? Any team?
Yeah. Or any of the teams, it's like up for grabs. No marks, just fun. You guys can just keep answering.
Yeah.
Speaker, keratoplasty,
Yes.
Okay.
vitrectomy,
Okay.
Retinoblastoma.
Okay.
Why should you guys have all the fun, huh?
Yes, ma'am.
Any? Yeah. Correct. Tell.
Enough.
What?
Second wala.
Trabectomy.
Okay, right. Next. Last, fifth one, I guess.
Retinoblastoma.
Fifth one.
Already said.
Option
Fifth one,
5.
fifth one. Option 5.
Oh.
So ophthalmoplegia.
Ophthalmoplegia.
Yeah, correct.
All.
Fourth
So all of
one
you get
would be
all
answer.
6. Good job. All right. So we're going to give you the scores now, Dr. Harshal. So the scores are team 1 gets 5 points, team 2 you get 5 points, team 3 you get 6, team 4 you get 5 points, team 5 you get 5 points, and team 6 you again get 6 points. As far as the quiz was concerned, for the PPP squad, your score was at a 0. KY Jellies, you got 3 correct and 1 wrong, so your score is at a +3 with -2, so it becomes a +1 for you. Ora Serata, you guys scored 0. Visionaries, you got 1 right and 1 wrong, so your score is at a total of -1. And Vision Makers, you got 3 correct, so you're at a +3. I got this, you got 1 correct, which is +1. Is it all fine with all of you? Does it tally with your marks?
Yes, ma'am.
All right, perfect. So
Perfect.
this was your scores, and it was amazing having all of you. Over to Dr. Prasanna to give it a wrap to the session. And we need that photo. I see KY jellies all a smile. You guys are very, very happy kids.
KY jellies are a vibe.
Yeah, very happy kids.
They are
It's very
vibing.
fun to see. Yeah.
With their mobile taking selfies.
Yes.
Yeah, all right.
So
Can
I
we
think
have the
with that,
rest of you?
yeah.
Visionaries, Dr. Afzal, the PPP squad,
I think huge shout out to
Aura
Dr.
Sirata. And you guys should actually give yourselves a huge round of applause. You were really good. You were fantastic, awesome. I think, and
I
this is
think
like the wrap to the semi-finals, to the prelims.
prelims,
So we'll next see
prelims,
you at the
semi-finals,
semi-finals.
prelims and semi-finals. So with that,
Okay,
again,
all of you
actually,
there? No, I can't see all the teams. I got KY. I got this. Visionaries, PPP. Yes,
filmmakers,
you guys are there.
PP
Vision makers,
squad.
get the rest of you on there.
Yes. Arshal, do we have any more slides?
Yeah,
Nope.
sir. We just want to show
Oh, yeah, we have the
Yeah,
we want to
certificate
invite.
presentations. We will be
super.
sharing all these certificates with you
Arshal,
on the participants group as well.
can we have the names from first? Go
Yeah.
back left.
Yes,
Yeah.
sir.
Thank you, Arshi and Arshil. I think you guys have really put a lot of hard yards for this. Despite Arshi's having a lot of personal. Son was not well, but still that is commitment for you. Again, Dr. Arshil also, despite multiple commitments, Arshil always shows up for YOSI. So I would like to formally again with my co-moderators, Dr. Arshi and Arshil. Dr. Soumya Kashyap, congrats again, each one of you are winners. Dr. Jyoti Garg, next slide, Dr. Nehal Bandari, Dr. Akansha Das, Dr. Disha Shri, Dr. Mukul Gupta, Dr. Jan Chingling. If I'm pronouncing you wrong, kindly please pardon my vocabulary. Dr. Maggie N.G. Boon Yi, Dr. Chong Karyong, Dr. Pranjal Atolia, Dr. Sankriti Pandey, Dr. Shaifali Patel, Dr. Surbi Bharadwaj, Dr. Rekha Bharadwaj, Dr. Nitin Gaba, Dr.
Sir,
Ishrat,
they are not there.
not there, Dr. Mohammed Afzal, Dr. Abhishek Singla, Dr. Shahil Kumar, and of course, again, a huge shout out to Arshi, Dr. Arshal, and all the colleagues of my team, this wonderful team, our team iROCK, headed by Dr. Nupur ma'am. I think madam has spoke enough about it. And also we would like to thank our other partners who are supporting it, like Numerotech is supporting us from the back end. Again, thanks to Numerotech, and also for the flyers, for the seamless technological work. And if at all any one of you are seeing this, you guys are not members yet, you want to become members yet, just scan this QR, become a member, board the next flight near to you towards New Delhi on July 9th, and come to YOSICon, and you will see the perks, many more, for why you need to be a YOSI member. This is by the YOS, for the YOS, a conference being done. And not only that, the vision of our president is to go international, and that is why it is International YOSICon. See you guys all there. And with that, I want my co-moderators, Dr. Arshil and Dr. Arshi, to say the closing comments, who have taken a lot of pain in getting things in order for today, and also for taking me along with you guys. Over to Arshil and Arshi. Have a closing comment, guys.
Rock on, guys. Just keep learning, keep growing, and hope to see all of you at YOSICon. Harshal.
Thank you, all the participants. It was very good working with you and for you, preparing for you. Like not only you, I told it is learning for us also to prepare and all. Thank you for giving us such opportunities. Moving on, just we would like to see you at YOSI Con International Conference on June. Thank you. Moving to photo session.
All of you need to scooch in into one single frame so that the background, and you can, if you want, you can switch off the background. I got this. I can only see one person. Manjula ji.
Yes, doctor.
Yes, please. We have to wait for all the team members to come in. It's like ghosts over here. You guys can switch off the virtual background. I think that is causing.
I think with Dr. Pranjal,
Yeah, Ora Serata, you guys can switch off the virtual back. Same, I got this. Take your virtual background off. Get all three of you together. PPP squad, where's the third? The squad has two.
She's from another ID.
All right, perfect.
Taken,
ACG
doctor.
attack, hands up.
Taken, doctor.
Thank you.
Good. Last, we just want to know your experience. Any participants wants to say anything about iROCK
Manjula ji,
session?
I think we can stop the
Stop
live
live.
streaming
Yeah, we
now.
can stop live.
Okay, doctor. One moment, doctor.